حضورنا الكريم، نرجو الالتزام بالمقاعد لبداية الحفل.
فرع وزارة الصحة، سعادة سعادة الرئيس التنفيذي لتجمع حائل الصحي، سعادة الرؤساء التنفيذيين لتجمع حائل الصحي، سعادة الرؤساء التنفيذيين للتجمعات الصحية الشمالية.
عبد الله الرخيص ليلقي كلمته في هذه المناسبة.
للتجمعات الصحية في الشمال، أصحاب السعادة، ضيوف ومتحدثي المؤتمر الكرام، أيها الإخوة والأخوات ضيوف منطقة حائل أبطال الصحة، السلام عليكم ورحمة الله وبركاته. يطيب لي أن أتشرف بمشاركتكم مراسم افتتاح المؤتمر الثالث لأمراض وجراحة القلب الذي ينظمه تجمع حائل الصحي. هذا المؤتمر المتميز الذي يطوي عامه الثالث برؤية وثابة وأوراق عمل وبحوث علمية وتطبيقية استثنائية وحضور متميز، حيث زادت أعداد المسجلين لحضور المؤتمر على الساعة القصوى وبلغت أكثر من 1100 مشارك متخصص شغوف بتقدم علاج وجراحة القلب. ونظمت على هامش المؤتمر وللمرة الأولى ورش عمل متقدمة لقسطرة الإنعاش القلبي والاستجابة السريعة. ومثل وجود هذه النخب في المؤتمر فرصة ذهبية لتبادل الخبرات والتجارب والمستجدات العلمية والتطبيقية في أمراض وجراحة القلب. أود أن أنتهز هذه الفرصة للتقدم بالشكر الجزيل والتقدير لمعالي الدكتور ماجد الفياض الرئيس التنفيذي لمؤسسة مستشفى الملك فيصل التخصصي ومركز الأبحاث، الذي حال سفره لليابان دون مشاركتنا اليوم في هذا المؤتمر الهام، وحرصنا للاحتفاء بالتعاون الناجح بين التجمع حائل الصحي ومستشفى الملك فيصل التخصصي من خلال الاتفاقية التي وقعت قبل نحو 4 سنوات لتطوير مركز القلب في مستشفى الملك سلمان التخصصي التابع لتجمع حائل الصحي، والتي حققت الكثير من النجاحات والإنجازات. فشكرا لمعالي الدكتور ماجد، وشكرا لقيادات وفريق مركز القلب في مستشفى الملك فيصل التخصصي بالرياض على هذا الأداء الرائع والدعم المتميز والدائم. وأود أن أشكر أخي وأستاذي سعادة الدكتور عبد العزيز الحميضي الرئيس التنفيذي السابق لتجمع حائل الصحي لحكمته وبعد نظري في تطوير هذه الاتفاقية التي ساهمت في تطوير مركز القلب بحائل. والشكر موصول لأخي وصديقي العزيز الدكتور فايز المياح المدير الأسبق لمركز القلب بمستشفى الملك سلمان التخصصي ومن تبعه بإدارة المركز. وأود أن أشكر على وجه الخصوص القيادي المتميز والمعطاء الدكتور عبد الله الراشد مدير المركز حاليا، ولجميع مسؤولي مركز القلب في مستشفى الملك سلمان التخصصي. أيها الإخوة والأخوات، افتتحت أول إدارة للصحة في المملكة قبل نحو 100 عام، وبعد نحو 25 سنة تم تأسيس وزارة الصحة في منتصف الخمسينات الميلادية، وأقرت أول خطة صحية عام 1979. ثم تواصلت الإنجازات لتطوير الخدمات الصحية التي خدمت السكان لنحو 90 عاما. وتخلل هذه المرحلة صدور النظام الأساسي للحكم، والذي ذكر في مادته 31 ما نصه تعنى الدولة بالصحة العامة وتوفر الرعاية الصحية لكل مواطن. ونص في المادة 27 على أن الدولة تكفل حق المواطن وأسرته في حالة الطوارئ والمرض والعجز والشيخوخة. وقد أطلق نموذج الرعاية الصحية الجديد قبل نحو 8 سنوات في بواكير إطلاق برنامج التحول للقطاع الصحي الشامل في المملكة، والذي يعد من أكثر برامج التحول الصحي على مستوى العالم شمولاً وعمقاً واتساعاً، ليشمل كافة مناحي تقديم الخدمة الصحية السكانية والعامة والعلاجية، إن لم يكن الأشمل على مستوى العالم. نحتفي أيها الإخوة والأخوات من خلال مؤتمر أمراض وجراحة القلب في نسخته الثالثة، والذي ينظمه تجمع حائل الصحي بتحقيق إنجازات نوعية قادها أبطال الصحة في منظومة وزارة الصحة وشركة الصحة القابضة والتجمعات الصحية. وقد أكد مؤتمركم المبارك هذا ما تم تطبيقه بالفعل في المرافق الصحية على مستوى المملكة، أكد أنه النموذج الذي سيحدث التغيير الحقيقي المأمول. أيها الإخوة والأخوات، انتقلنا من كون المعرفة والسياسات التدخلية تلهم الممارسة إلى مرحلة الممارسة الناجحة والمحفزة، والتي تلهم المعرفة وتضع مسيرة التحول في جانبها التطبيقي والتشغيلي في مسارها الصحيح. يمثل هذا المؤتمر النوعي علامة فارقة لمرحلة انتقالية مهمة في تطبيق نموذج الرعاية الصحية في مسارات أمراض وجراحة القلب والسكتات والجلطات القلبية. إنني سعيد ومبتهج بتطور أبحاث وأوراق العمل التي قدمت في المؤتمر الثالث لأمراض القلب ولا تزال تقدم، والتي تتواءم مع السياسات ومسارات الرعاية الصحية السعودي وتواكب التقدم العلمي. أود أن أشكر سعادة الدكتور نايف الغصاب وزملائه وفريق المؤتمر المتميز والمشاركين بتنظيمه وفريق التطوع الصحي والاتصال المؤسسي على جهودهم المقدرة في إنجاح هذا المؤتمر الهام. وأود أن أشير إلى جودة الأبحاث المقدمة لهذا المؤتمر المتميز، لا سيما بحث تخطيط صدى القلب المرتكز على الذكاء الاصطناعي للتشخيص القلبي الدقيق في المملكة العربية الصحيح للتقنيات التي تساهم في دقة التشخيص والإجراءات الطبية المتقدمة. وأود أن أشير كذلك إلى أحد أوراق العمل التطبيقية المتميزة التي تساهم في تحقيق مستهدفات التحول الصحي وإثراء تجربة السكان والمرضى والمستفيدين، وتعزز الاستدامة المالية للخدمة الصحية، وهو بحث أثر عدم التزام المرضى بأدوية خافضات ضغط الدم والعبء الاقتصادي على نظام الرعاية الصحية في منطقة حائل. وقد أكدت نتائج البحث على أن عدم الالتزام بالأدوية بالإضافة إلى أضراره الصحية يساهم في رفع التكلفة الاقتصادية. أيها الإخوة والأخوات، بفضل الله ثم بدعم قيادتنا الرشيدة ومتابعة صاحب السمو الملكي الأمير عبد العزيز بن سعد بن عبد العزيز آل سعود أمير منطقة حائل وسمو نائبه، وبالجهد المبارك من قيادات وأبطال الصحة المتميزين، أنجزنا الكثير. أثبتت التجمعات الصحية قدرتها وتمكنها من تطبيق مبادرات ومسارات نموذج الرعاية الصحية السعودي، وأصبح لدينا كم هائل من المنجزات وقصص النجاح ولله. أبدع تجمع حائل الصحي وتجمعات الشمال والتجمعات الصحية على المستوى الوطني ومراكز طب وجراحة القلب في إثراء تجربة السكان والمرضى في تعزيز سلامة القلب من خلال الأداء الرائع لمسارات أمراض القلب ومسار رعاية الأمراض المزمنة. وعندما نتشاركها في مثل هذا المؤتمر وبين المستشفيات والتجمعات وفرق العمل في الميدان، سيكون لها أثر كبير وتسريع لعملية التطبيق. إنني سعيد جدا بمشاركة قامات وطنية متميزة في هذا المؤتمر، وأود أن أنقل تقدير زملائي في المجلس التأسيسي الصحي للشمال وزملائي قيادات ومنسوبي تجمع حائل الصحي لهم ومشاركتهم الفعالة في أعمال المؤتمر الثالث لأمراض وجراحة القلب في منطقة حائل، ولن أتمكن من حصرهم جميعا، لكنني أرحب بأخي سعادة الدكتور أحمد صلاح حرسي الرئيس التنفيذي للمدينة الطبية في جامعة الملك سعود بالرياض، والدكتور وائل قشقري رئيس جمعية قسطرة القلبية، وسعادة الدكتور عادل طاش المدير العام التنفيذي لمدينة الملك عبد الله الطبية، وسعادة الدكتورة مرفت الأصنج رئيسة قسم القسطرة في مستشفى الملك فهد للقوات المسلحة والمتحدثة في المؤتمر الأوروبي والأمريكي، وهي أول استشارية قسطرة سعودية، ونخبة متميزة من استشاري طب وجراحة القلب والخبراء المتخصصين والباحثين المتميزين. بلا شك مع هذا النجاح والإنجاز هناك الكثير من التحديات التي أيضا علمتنا الكثير في طريقة التعامل مع متطلبات التحول. هذا المؤتمر أحد الوسائل التي نجابه بها مثل هذه التحولات. لذلك اليوم يا أصحاب السعادة والعلماء ومقدمي أوراق العمل لهذا المؤتمر الهام، وفي هذه المرحلة من تطبيق نموذج الرعاية الصحية السعودي، نحن بحاجة أكثر من أي وقت مضى لتمكين مختلف نحتاج في تجمعات الشمال الصحية على وجه الخصوص للاستمرار في هذا التعاون والتكامل البناء للمضي قدما في مسيرة تطوير الاستجابة الفعالة لأمراض القلب، ودعم مركز القلب في تجمع حائل الصحي ومراكز القلب في تجمعات تبوك والجوف والحدود الشمالية. ونحتاج لتنظيمات أكثر مرونة وفاعلية تدعمها في تمكينها لموظفيها في الصفوف الأمامية، ونحتاج لتحول مؤسسي وهيكلي ودعم للقيادات التنفيذية. إن العناية بصحة نطاق سكاني محدد هو من الأسس التي يقوم عليه التجمع الصحي، فهدف التجمع الرئيس هو أن يفهم احتياجات الرعاية الصحية للنطاق السكاني الخاص ويقدم الخدمات التي تلبي هذه الاحتياجات كمؤسسة واحدة مرجعية. لا يمكن للتجمع الصحي النجاح في مهمته دون تطبيقات إدارة الصحة السكانية عبر كل مستويات الخدمة، ابتداء من الفرد كمستفيد فاعل ومبادر للعناية الصحية، والأسرة ودورها الحيوي في الحد من الآثار المزمنة وأمراض نمط الحياة بوابة أمراض القلب. لا يمكن أن يتحقق مثل هذا النجاح دون التطبيق الناجح لنموذج الرعاية الصحية الذي يحقق أيضا الاستدامة المالية. معنى أن يكون المستفيد محور خدمات الرعاية الصحية هو أن يكون هناك تكامل عميق بين المرافق والأقسام التي تقدم كل الخدمات الوقائية والتشخيصية والعلاجية على حد سواء، لتكون كل الخدمات التي يحتاجها المستفيد منسقة ومتكاملة حسب احتياجاته. ولذلك فإن التكامل يبدأ من الخدمات التي تقدم للمستفيد عن بعد وفي منزله أو في المجتمع في مراكز الرعاية الأولية، وبهذا يتحقق توفير الخدمة بسهولة سواء كانت تشخيصية أو علاجية. إن نجاح تطبيق نموذج الرعاية الصحية الذي احتفينا به مطلع الأسبوع بتكريم تجمعات مستشفيات متميزة هو دليل على أن هذا النموذج المقتفى، نموذج الرعاية الصحية السعودي الجديد، هو الوسيلة التي يمكن أن تساعدنا في التحول وتحقيق أهداف الصحة. أيها الإخوة والأخوات، إن نجاح نموذج الرعاية الصحية في تطبيق نجاح نموذج الرعاية الصحية في تطبيقاتها المتعلقة بأمراض وجراحة القلب هو دليل على وضوح رؤية القيادة الرشيدة والتزامها تجاه مواطنيها وسكانها وزوارها، ولطالما نقل لنا معالي وزير الصحة حرص واهتمام سمو ولي العهد مهندس الرؤية أيده الله على تحقيق أهداف برنامج التحول الصحي الفريد في شمول مستهدفاته، ونحن بإذن الله تعالى باقون على العهد ومتطلعون وشغوفون وممتنون. والسلام عليكم ورحمة الله وبركاته.
حضورنا الكريم، أما الآن مع تكريم رعاة هذا الحفل الكبير. شركة أبوت ميدزيرف، شركة أبوت الجيل، شركة ميدترونيك، شركة نوفارتيس، شركة أسترازينيكا، شركة كورديس، شركة إدوارد، تكريم تشريفي لرئيس جمعية القسطرة القلبية في السعودية الدكتور وائل قشقري. الدكتور أحمد صلاح حرسي المدير العام للتنفيذي للمدينة الطبية بجامعة الملك سعود. أمراض القلب ليست مجرد قضية طبية، بل هي قضية حياة تمس كل بيت وكل عائلة، ولذلك جاءت أهمية هذا المؤتمر، والذي نأمل أن يكون محطة ملهمة للجميع، مليئة بالنقاشات المثمرة والأفكار الجديدة. فلنبدأ معا هذا الحدث الكبير، ولنضع قلوبنا وعقولنا في خدمة قلوب الآخرين. أهلا وسهلا بكم ضيوفنا في الجانب العلمي من المؤتمر.
ورحمة الله وبركاته. Ladies and gentlemen, welcome to the first session of exciting. We will start with heart failure. As you know, heart failure is an epidemic and need multidisciplinary approach. We have expert speakers. Let me introduce our guest, Dr. علي المسعود, Dr. أحمد الهرسي, Dr. فهمي الكاف, Dr. فخر الأيوبي, Dr. علي التبيناوي. The first presentation will be by Dr. Ali Al-Masoud. He is interventional cardiologist and heart failure consultant in King Faisal Specialty Hospital. He will talk about revascularization in ischemic cardiomyopathy.
سعيد جدا وش ايوه اتمنى اني اقدر اقول شعر ولا شيء تكون سلايد جاهزه يليق بهذا البلد الجميل. بس البيت الشعر الوحيد انا ما احفظ شعر، بس البيت الشعر الوحيد اللي له علاقه بالديار والناس، وما حب الديار يشغفنا قلبي ولكن حب من سكن الديار. مروا على الديار ديار سلمى قبلوا ذا الجدار وذا الجدار. فيه سلمى وموجوده. طيب now we should move to the science, I guess. Again, I'd like to thank the organizing committee for giving me the chance to be part of this fantastic meeting, and it put me under a little pressure being the first speaker in this meeting. So I try to stick to the time. I need 15 to 20 minutes to cover this important subject. My task to go through the revascularization options in patients with ischemic cardiomyopathy. How can we move that? Can you go back? Anyway, as I said, my task to talk about ischemic cardiomyopathy, and needless to say, the most common cause of heart failure is ischemic cardiomyopathy, and the most serious associated condition in patients with heart failure is ischemia. So ischemia is very poor prognostic factor for patients with heart failure, and patients with heart failure, most of them, or the most common cause of having heart failure is ischemia. So you need to keep this in mind. And you need to understand the and you need to keep in mind the possible etiologies of pathogenesis to understand the relation between ischemia and heart failure, and this probably will reflect on your management choices and options. So the heart failure and ischemic patients could be because of infarction and scarred myocardium, could be because of hibernating myocardium, or other etiologies like significant valvular diseases like ischemic MR or endothelial dysfunction. Let me just take you through one of the most important heart failure registries, Swedish registry, evaluating more than 40,000 patients, and they divided heart failure patients into different classes of heart failure, HFrEF, HFpEF, and mid-range, and then they looked for presence of ischemia, and they found the worst group was those with ischemic heart disease and heart failure with reduced ejection fraction. This was the worst group with regard to prognosis, mortality, and cardiac death. This is just to reflect to you the importance of evaluating and managing ischemia in patients with heart failure. Knowing this, if you look at patients admitted with heart failure, not all of them being investigated for ischemia. In fact, there are few reports have shown that less than 50% of patients admitted with acute heart failure being evaluated for ischemia, and this is not a benign condition. I mean, if you do not, they divided the patients into two groups: those with acute heart failure. The patients underwent ischemic workup, and patient did not go through this, and the mortality was worse on those who were not being evaluated for presence of ischemia. So, evaluation of acute ischemic event in patients with heart failure is mandatory. And it's not, I mean, just to remind you, one of the DCM registries, post-cardiac transplantation, they found at least 11% of those who've been labeled to have dilated cardiomyopathy have ischemic cardiomyopathy. So do not overlook presence of ischemia in patients with acute heart failure. And so why we are evaluating these two clinical conditions? We need to know, is intervention safe for patients with acute heart or with established heart failure? Can we improve their symptoms or survival? Is there any role for viability testing for this group of patients? First, let me just go through the safety of intervention for patients with heart failure. This is not a new registry, it's not more than a decade back, evaluating patients going for CABG with severe LV dysfunction, and the mortality was 5%, which is very reasonable, very acceptable, and 5-year survival was 75%. So contemporary interventions for patients with heart failure is relatively safe and may have an impact on prognosis. So why should we revascularize patients with heart failure? The potential benefits are like this: improving the ejection fraction, reducing the inducible ischemia, ventricular arrhythmias, remodeling, and improving the symptoms of congestive heart failure. So according to the classical concepts, revascularization combined with guideline-directed medical therapy may improve systolic function, and by restoring sufficient perfusion to dysfunctional yet viable myocardial segments and preventing new ischemic events. We have wealthy of registries and observational studies evaluating patients with ischemic cardiomyopathy, and the Restore registry, one of these studies, they evaluated those with ischemia who underwent high-risk intervention, and they found improvement of ejection fraction, and the improvement of the ejection fraction was associated with more complete revascularization. So intervening with these patients may result in improvement in their prognosis and outcome and symptoms as well. This is one of the meta-analyses evaluating more than 20 studies assessing patients with ischemic cardiomyopathy, and this study has compared patients went for surgery versus medical therapy, PCI versus medical therapy, and PCI versus CABG. And they evaluated the survival benefits. So those who underwent revascularization did better than those who did not go for revascularization, and surgery was more favorable than angioplasty in this group of patients. Now, this subject will never be complete without going through STITCH trial, which is probably the only randomized clinical trial assessing CABG in patient with ischemic cardiomyopathy. Though this study is relatively old study, but it is the only study, only prospective randomized controlled trial investigating the role of CABG with patients with ejection fraction less than 35%. The study evaluated more than 1,200 patients, divided them into medical therapy versus bypass surgery, and the first report of the study did not show difference between the two groups. However, long-term follow-up, 10 years follow-up, found improvement of survival in bypass group. So surgery in patients with this, in proper setting, in patients with ischemic cardiomyopathy may improve survival and save lives. What about angioplasty? The only randomized clinical trial so far evaluating PCI in patients with ischemic cardiomyopathy and comparing them to guideline-directed medical therapy is Revived BISIS 2, which was released a few years ago. And unfortunately, the study did not show difference between medical therapy group and BCI group. However, this is the only randomized clinical trial that we have, so I'm not sure if this is enough, and why should surgery be of value while BCI did not show any difference? I mean, there are multiple reasons behind this, and there are multiple differences between the two studies. For example, if you see the STITCH trial, the number of patients was much higher. The time frame, if you remember, the outcome was positive at 10 years follow-up. So the short-term follow-up did not show benefits. So we don't know what will happen to revived group if we follow them more than 5 years or up to 10 years. Again, the STITCH patients were younger, and they are at higher risk. Most of them, or more than 78% of them, have previous MI, while only 53% of revived patients have previous MI. So STITCH group were younger and higher risk, and this may reflect the benefit of surgery in this group in contrast to BCI. And these two studies has their impact on the guidelines. The EEC guideline 2024 as well as ACC guideline 2023 has given bypass surgery for ischemic cardiomyopathy class 1 recommendation, while they gave class 2B recommendation for BCI. So still surgery is superior to BCI for patients with ischemic cardiomyopathy in proper setting. However, remember, not every patient with ischemic cardiomyopathy will be accepted by the cardiac surgery. So still there is, in fact, and the more than two large observational studies, still, even after this evidence that we have, most of the patients with ischemic cardiomyopathy, they'll go for PCI because of non-acceptance or turning down by the surgeons. So now let's try to answer the question of viability. Do we need to assess for viability? Theoretically, yes. Viability may help to predict the response to revascularization and patient selection. It's a marker for prognosis and may influence response to the medical therapy. And there are many observational registries has shown the value of viability in patients with ischemic cardiomyopathy. However, if you go to the STITCH trial subgroup, the viability has no impact on the outcome, as well as the revived BISIS 2. So we don't have solid evidence that says viability has an impact on the outcome, but this doesn't mean we should neglect or not to do viability, but we should take it in the context of the patient's presentation and other risk factors. And these are the clinical trials that did not show any value of viability for patients with ischemic cardiomyopathy. However, I still, I mean, most of the recommendation recommend utilizing PET scan, SPECT, and cardiac MRI to assess for prognosis and guide therapy for patients with ischemic cardiomyopathy. So in conclusion, ischemic cardiomyopathy therapy is multifaceted, including revascularization, pharmacological and non-pharmacological strategies, and guidelines still recommend CABG over BCI for patients with ischemic cardiomyopathy. And CABG has not been compared to BCI head-to-head in this group of patients, so this is knowledge gap. And the role of viability testing in the setting of ischemic cardiomyopathy is still controversial. The observational studies support its use. However, STITCH trial and Revived, they did not show value of doing viability testing for these patients. So we need probably to take the patient as a whole and take the context, the center experience and comorbidity for this patient to help them the most, and always keep patient-centered care in mind. And we should have a heart team discussion for this high-risk group of patients, including pre, peri, and post-care. And selecting a revascularization modality should be determined through shared decision-making and a risk-benefit assessment. And thank you.
Thank you very much, Prof. Ali, for this comprehensive review of this controversial issue. Now we will keep question to the end of the session. We will move now to the guideline-directed medical therapy, how to optimize these medications. As we know, the best one to talk about this is an expert clinical pharmacist, Dr. Fakhr Al-Ayyubi from King Saud University. She will enlighten us about the technique and tips and tricks to optimize guideline-directed medical therapy.
Thank you very much. السلام عليكم ورحمة الله وبركاته. جمعة مباركة إن شاء الله، وتقبل الله منا ومنكم صالح العبادة. فرصة الحين برضو أبارك Is my voice louder now? Can you hear me? Okay. مبارك لكم طبعا اليوم الوطني، خلاص شارف على القدوم إن شاء الله. يعني كاتش very good catch لحائل، منطقة حائل إنها اختارت الأسبوع اللي قبل اليوم الوطني. Thank you very much for the invitation. And it's, I think, time to take the challenge to talk about medications. Honestly speaking, I liked your, Dr. Ali, introduction about the ischemic heart disease. And of course, very important for us as a pharmacist, we need to help each other. But sometimes you take a good decision, but in a late time. Or sometimes it takes a long time to take the right decision, but there's no facilities for that. That's why our focus today as a pharmacist, we'll talk about the medications, and we have a lots of success story with medications, and we know that optimization of medication had really shifted some patients and discharged them from our clinics, and they are just actually there for a follow-up. So thank you very much for making my life easy, Dr. Ali, and I think it's time now just to go through the slides, because I would like, first of all, of course, to talk about the conflict of interest. 100%, there's no conflict of interest. And the other thing is that I always use this slide to tell you that we as a pharmacist, not competing with physicians, we are there actually to work together for the patients. And for the patient care, we need, first of all, a proper diagnosis and, of course, proper medication. The very beginning question is that, how can I do this? How can I optimize the medication for the patient? And if you have the facility to have a specialized clinical pharmacist in your center, believe me, you are in a safe hand. But I know most of us, we don't have this luxurious tool, but at least we can help each other, and also we can help getting the proper guideline and proper pathways. Now, we started a long time ago. We'll talk about this in details. Any help in here? It's not moving. واضح برين حق الكلينيكال فارماسيست عمل مشكلة في السلايد. Can help? Moral. Okay, finally. So we need to cover some facts. And facts are important because we are not there just to mimic the global data. We're not there to take international guidelines and apply it on our patients. We found from our own experience and from our own data that some guidelines do not work with us. We cannot have the same guidelines everywhere. The other thing is that we need to talk more about what is the guideline-directed medication therapy, GDMT, because some of us does not know exactly what does it mean. On the other side, optimization, how to do, what's the barriers, how to get the outcome, and of course, there should be some local data. That's why I'm here, because I am the president of the pharmacy group in the Saudi Heart Association since 7 years back, and I have a very good data that I want to share with you. Take-home message is important, and what is the recommendations for the future of taking care of your patients. I know it's a very crowded slide, but it's very important to start with. When I'm talking about heart failure, I have to know some facts about it. It's a complex, it's a burden, it's really consuming our budget in the country, and of course, the morbidity and mortality is our target. I don't want just to save the patients, I want to save their lives, the cost, and also a very good quality of life. All these facts are important to put them in front of you when you're talking about a patient medication. Now, another thing is the definition. In Saudi Arabia, we use just to mimic definitions, but from our own experience, this is the final definition, and I want you to focus with me about the number of ejection fraction, because today we're going to talk about the HFrEF, which is a reduced ejection fraction, because there's no time to cover others, but 100% other definitions are important for me. This is numbers, it varies, but it is the indicator for me that I'm doing a good job or not in the clinic. For example, I know some of the patients who had really a 15 ejection fraction, but they had no sign and symptoms, so we had to re-investigate again. So that's why numbers are important, but they are not the only guide for you. You have to have your sense and, of course, the clinical features, which is the sign and symptoms. The most important part for me as a pharmacist there, when I'm in the clinic, I need to help my team to decrease the hospitalization of the cardiac patients. Heart failure hospitalization, it's a fatal problem that we're trying to face in a challenging way. Within 5 to years of diagnosis of heart failure, we lose more than 70% of the patient, and that's why multidisciplinary team was there, have been introduced 2015 in King Saud University, and it just went viral. We have heart failure clinics all over the kingdom, and I would like to share, of course, with you our experience in Saudi Arabia. Now, very important for me to involve an expert team. It's not just being there with a good knowledge, of course, what to do, what's the pathway, and after we have the multidisciplinary team, we should have some goals. These goals has to be achieved with the proper GDMT, because GDMT now it's our tool and our clue for a proper management. What is the new guidelines or the most updated guidelines for GDMT for HFrEF patients? Please focus with me, because we have very serious slides coming now with very big debates in the cardiology field. And I do really face a lot of debates in our clinic, but it's a very healthy debate, because in the end, it goes with the patient's benefit. Now, very important, of course, the very big, strong bodies in regulation has really gave us very good slides to cover, and of course, to give the definition of the proper medication and what's the optimization of it. We all know that stage A and stage B, most of the time, we do not catch these patients. Most of the patients comes to us with stage C. What do I mean by stage C? Now the patient is heart failure with symptoms. And we're trying our best in Saudi Arabia to go step back to get patients from stage B or A. That would be a great job. But in the end, stage C is the one that we are dealing with in the clinic. And the most important part for stage C, I want to stabilize those patients, and it's be much more success to put them back again to a better stage. Very important for us to focus about, first of all, the most important part for me, it's diagnosis. Lots of patients, they come into the emergency, they discharge, and they're not labeled heart failure. And this is really a lack of knowledge. That's why we should focus on that. An outreach has been started 2015 until now. Everywhere in Saudi Arabia, we are there just to educate our colleagues anywhere in any specialty that what is heart failure and what is the prediction and what diagnosis tools they should go through. Resolution of symptoms is important for those patients because they come to you asking for help. So if you do not work on the symptoms, again, it's another failure. Persistent heart failure is now our most of the time experiencing because we have labeled the patients in Saudi Arabia. We are way behind. That was 10 years back, but now we are just in the front, and we know our patients, and most of our heart failure patients has been labeled the last few years. Worsening heart failure, it's another story, and we had a very good workshop last year in Abu Dhabi, where we were talking about transplantation and what to do next, the LVADs and so on, which is outside the scope of this conference. Another important thing is that we need to know the cause. Now you will tell me, you are a pharmacist. Why do you need to know that? It's not only me, the whole team. As you could see from Dr. Ali's presentation, ischemia by itself, it's a cause, which means there is a place where it's damaged and it's irreversible damage. So this is my capacity as LV contractility. As a pharmacist, I need to know, should I push harder on which medication, and should I give them all, and what I'm expecting from this patient. So that's why I need to know the cause. Cause is important because it will take you to another part. You should treat the cause if you can, and if it's treatable, then you focus on the heart failure outcome. And this is why there is a GDMT. Another important thing for me, if I know the non-ischemic cause, you could see a huge, tremendous amount of comorbidities that are there, and they had to be, of course, diagnosed in order to give the proper medications and doses for those patients. So we work in parallel, treating the heart failure symptoms and signs and taking the patient to another level, and of course the other comorbidities. This is how you deal with patients. Now, the algorithm of heart failure are based on classifications of heart failure. We know the NIHA classes, of course, and we have to know which class my patient is, and of course, what diagnosis tools they did. And this is very important as a pharmacist. I cannot receive any patients without having an ECG. I need to see that. I don't need to read it because I trust my team, but I need to see ECG, and I need to see the echo, and of course, the proBNP with the biomarkers, the kidney function, and the lab results. Lab results for anemia, for hypothyroidism, and so on. If I don't see this full in the patient's file, I need to ask for it because this will guide me and the team to the proper medication. Now I know my patient, I know the ejection fraction. Let's start. By the way, sometimes you might face a cases where you started, let's say, as a HIF-PIF, and then you discover they are HIF-RIF. Now this, again, comes with the follow-up and, of course, the evaluation of the outcome. Now we're to the core of this presentation, which is the medications. As I told you, in stage A and stage B, most of the time, they are not yet heart failure, but we have special recommendations for those patients. Some of those patients, you see them in the onco clinic, for example, the ones that are going to receive chemotherapy, they are still in stage A because their heart still is not yet ischemic or toxic with the chemotherapy. In this case, you have tools and recommendations covered by the global guidelines, what to do. Even in stage B, what kind of medication we should go with, and all of them are class 1A. So this is, again, something that you should focus on and emphasize with your team, that if you receive a patient in such stages, please do an action. What about C and D? And this is where the core of this presentation is for. Now you can see that in step 1, first of all, we have to diagnose the patient, as I told you, and see the ejection fraction. In this case, we have to see the number of the ejection fraction. Is it 40 or more, 40 or less? The cutoff usually is 35, because this is where we have to do another action. Now you can see from the green boxes here that ARNI in NIHA class 2 and 3, ARNI, ARBS, ACE, whatever you have, of course, we have special recommendations for that, but I mean the RAS inhibitors supposed to be there, and it's a class 1A, beta blocker, and spironolactone should be there, and SLG2 inhibitors. All of them are class 1A. Why are class 1A? Because they are working on morbidity and mortality with a very important and very positive outcome. Do I need to start only? The strategy is to start quick and with all. Before, we used to give one by one. We used to up-titrate the dose one by one, very slowly. It's not the case now. All the guidelines and the recommendations telling you, go ahead, you can start with 4 of them, minimum dose, and up-titrate it within 4 to 6 weeks. You don't wait for ages for that, especially if your patient is tolerating. So you have to reach the maximum tolerated dose on those patients as soon as possible. Now, these stage C have a cutoff point here. If they are with ejection fraction 40 and less, in this case, we'll go to step 3. Step 3 telling you that if your patient is an American African, in this case, they have a special scenario to go with, and it's adding on either the monodinitrates or isozorbidinitrates or hydralazine, and this is mandatory in those patients because it has proven that it will decrease the hospitalization. It will not work on the morbidity and mortality, but if your patient is still there, resistance with the full GMT, you have to have a clear cut of the GMT he's on, still not responding, given a good results. In this case, you have to introduce the hydralazine and nitrates. Now, what about if they are NIHA class 1 to 2 with ejection fraction 35 or less, and they survive till 1 year? In this case, we could introduce and evaluate them for ICD, and this, again, you have to refer them to the electrophysiologist experts that will give you a very good proper recommendations, and this is why we're doing that. It's to avoid the sudden cardiac death. It will not work on the morbidity and mortality, it will work on the sudden cardiac death. What about if they are NIHA class 1 and 3? And of course, ejection fraction is important. In this case, they have a QRS that is 150 or more. In this case, they are targeted patients with very important definition. They have the blocker, the LBB blocker. In this case, these kind of candidates are candidates for CRT rather than ICD. Why? They have to survive from ischemia, and this is actually part of the recommendations after 40 days of the MI. So you don't jump into this quickly, you don't jump into this without experience and without the outcome of your patients. Now, important for me is a very important step 4 and 5, because here where we have a very big debates all the time, and this is where we always face an argument about should I go and shift the patients to LVADs or surgery or CABG or all these kind of stages that we were discussing last presentation. Honestly speaking, most of those patients, I myself faced a lot of patients who were in step 3 or 4, and they were directly shifted to LVADs if they are young, if they have a good outcome, their kidney is improving, and so on. So again, this part of the schedule is actually debatable, and we have a very good experience in Saudi Arabia. We worked on the patient education. Sometimes the patient is part of the decision. And the other thing is that if your patient is going smoothly, there's no resistance of heart failure, go ahead and optimize the GDMT to the maximum tolerated dose and see which one would be the suitable part for your patient. Talking about stage C, talking about ejection fraction 35 and less. Now, as I want to emphasize here on a very important point is that the clinical tip in stage C is that you add the therapeutic part that I told you about, either ICD or hydralazine and so on, but you have to have a full 4 medications of GDMT with full doses, and you need periodical assessment for that. There's no plan that suit the patients forever, so you have to put this in mind. Now, let's talk about each drug specifically, and I'm going to just cover the 4 important drugs that we have to put our patient on. Renin-angiotensin system. We know that the HIF-RIF patients that are in NIHA 2 or 3 symptoms have to be there, and there have been studies proving that it decreased the morbidity and mortality of these patients. Another debates also telling us, should we wait for ACE, ARBs, or ARNI? Some studies, clinical trials, has supported that even introducing ARNI in this stage would be much better. The sooner, the better outcome. But again, this is something depends on the cost, the feasibility in your center, and of course, the availability for the patients. Now, another thing is that what is the high value? Value is important for me as a pharmacist. I need to have a cost-effective value. And if this value is not achieved, it's very hard for us to take the proper decision. And of course, in the HIF-RIF patients with NIHA class 2 and 3, the replacement of the RNA could be a solution sometimes. You might have a patients who have very good response, they're giving you a very good outcome, but these patients are not on RNA. In this case, you can introduce it, and this has been supported by the guideline. has been said already. What about the SGLT2 inhibitors? We know that these drugs has proven to be effective, decreasing the mortality on those patients. And even if the patients are not diabetic, still it's the class 1A, and your patient's supposed to be on it. With the heart failure doses, the other thing is that what about the value of this medication? It has proven to be cost effective by few studies yet, not finally approved, but some of the studies has showed for us the cost effectiveness part of this medication. What about stage D? And this is where we left it for discussion. You can see that patients who are already went through all the medications and they're still in the stage of worsening heart failure. In this case, they will be considered for LVADs. دكتور أنا بتكلم من غير slides. Okay, yeah, great. Okay, so in this case, these patients will be on LVADs or even preparation for transplantation. To have this proper decision, again, it has to be with consultation of our team and to have the final decision for those patients to be transplanted or not. I don't know why it's becoming slow. Okay, كل هذا done. Oh. What's happening? Okay. لا. This is the benefits evidence-based therapy for patients with HFrEF. You could see the 4 pillars are very important. Each one of them has proved the absolute reduction. When you have them all together, you can see that the absolute reduction has been better, and this also has been evaluated for the value of these medications on those patients and the proper cost-effectiveness outcome. What about patients who are hospitalized with decompensation heart failure? The same thing now. We have to first evaluate as if they are de novo patients and first target the goals of the GDMT. Why we need to know that? We could still summarize. We need the cause. We need to see if there is any adherence problem with these patients, medications, diet, and lifestyle modification. Can you please make the slides move for me? فيها مشكلة. طيب, GDMT during hospitalization, what applies for the patients in the ambulatory care applies for them, of course, in the hospital. But again, before we use not to start the medication unless they are discharged. It's not the case anymore. You can start as soon as possible in the hospital. Make sure they go to the same process, optimization of medications and avoiding the side effects. Even the mid-ref now, they are part of the mild reduction, LV, still they have the same, but instead of having them all as a 1A, the 4 pillars as 1A, it became 2A, and that's important because again, which one to start, what are we trying to achieve, is the heart rate problem, the cause, and so on. So benefits of GDMT has been proven. And as I told you, 4 of them has to be there within the 4 to 6 weeks, as soon as possible, so you could achieve the goal. Whatever other decisions that's going to be taken beside, it has to be taken care with the specialist in your team. Finally, it's actually, as I told you, the data which is local. And this local data took us a lot of work. Honestly speaking, it wasn't an easy job. And we had to first of all start with preparing the guideline in the Saudi Heart Association. We had an edited also now copy, and we were there embedded inside the clinic's heart failure specialist and of course nursing and dietitian and pharmacist, and it took us a lot of work. First of all, to work on the adherence, and we had a lot of studies. One of them was on the heart failure patients, and we have improved the adherence of those patients to their medication, and tremendously from 20% only to more than 73%, and we are very harsh on our patients to make sure that they will get the medication properly. It was actually a study done to see the vital role of clinical pharmacists in the multidisciplinary team, and it was part of my PhD thesis where I was able to achieve. And in this study, we tried to be not biased. We had some tools that we had to work on. We had it in several phases. Part of the phases was just actually describing what's happening, and we're trying to see the GDMT, is it happening or not? We measured that, and we tried to see the outcome of the GDMT on the patient's outcome. Now, why are doing that? All this for the proper outcome. And in this case, we said, okay, what about the signs and symptoms? A very clear, good results about improving the signs and symptoms in those patients. Another thing was the quality of life and the length of stay. Dr. More on these last slides. Okay. Now, the 4 pillars of medication have been measured, and you can see that we went from only just, some of them was only 60 or 40%. It ended up with more than 90% on all the 4 pillars of medications. Another thing, the adherence to whole medication. You could see in this curve, the green color in the last 2 years was tremendous improved, and that means that our patient not just adhering to their heart failure medication, they are also adherence to their other medication. Another very important measurements for us was the mortality rate. We had a more than 10 years experience, so we could measure the mortality rate. And you can see that before we had 10% mortality rate, it ended up now with 3.9, and that's very great data, especially for patients that are growing up with us. And that means we are doing a good job. Another thing is that the length of hospitalization, it's very important, and we know how important it is, have been also proved with a good results that we worked very good and positive on the length of stay. Quality of life, and this is why we are here for, honestly. This is why pharmacists are there in your clinic. We need to prove the quality of life. I don't want my patient to be alive, but dependent on others. I don't want them to be depressed. I don't want them to be inactive and so on. With this study and with measuring them with different questionnaires, we know them, one of them is the Minnesota questionnaire. The other one was the Kansas. Both of them have been given to the patient before and after, and very nice, very beautiful results that came out. One slide on, okay? So quality of life has been proven that is really a good result of this study. And from this, we said that multidisciplinary team are very important, heart failure programs are very important, and of course, يعني ما في animations حتى, okay? And again, medications are not taken, are medications that will not give an action. So that's why having this optimization process by itself, you should first of all work on the patient's adherence, tell the patients the importance of taking these medications, putting part of your team as a pharmacist with good knowledge, and applying the proper guideline, because if you do not apply the proper guideline, you will be adhering to a guideline that does not suit your patient. And of course, in the end, again, you will not achieve the adherence to the GDMT and not optimizing your medication. دكتور آخر سلايد بس لو تظهر لو سمحتوا. خلاص, there you are. Again, we are talking about women in power. We are there. Our colleagues, also the male pharmacists, are there, ready to serve, of course, our patients from all aspects. Thank you very much for giving me the chance. Thank you.
Thank you, Dr. Fakhr. It was very comprehensive, and I wish we have more time to discuss more issues about symptomization of the guideline-directed medical therapy. Now we move to new model of care in heart failure. As we know, the number of heart failure patients no health system can accommodate these numbers only with physician. So there is a new model, and Dr. Fahim Al-Kaf, he is a consultant advanced heart failure and transplant in King Fahd Medical City. He will talk to us about a model of nurse-led heart failure management.
Assalamu alaikum. Thank you, Dr. Halim, and thank you for all organizing committee. And thank you for the previous speaker who make my presentation more easy now. So it's continuous presentation about what they started, Dr. Ali and Dr. Rafa. Today, I have great opportunity to talk about the very important section in the cardiology and heart failure and in health sector in general. I will talk about the heart failure nurse and how they can lead the heart failure clinic in general. So can we start, please? Or I can choose. So just in general, heart failure is one of the highly prevalent disease in the world. We are talking about more than 65 million patients in general in the world, and the prevalence is about 1 to 3% of the population in any countries is with heart failure diagnosed. Actually, in one of the study who is assessing the prevalence in the Middle East or in general in heart failure, Saudi Arabia is one of the highly prevalence in heart failure in general, and we are talking between the 2 to 3% of the population with heart failure. And one of the trial coming from King Saud University, more than 12 years ago, they estimate the heart failure patient in Saudi Arabia more than 500,000 patients, and the additional per year is more than 30,000 patients diagnosed yearly with heart failure. So this is the heart failure clinical course. What the patient he will have from the initial diagnosis, when we saw him initially with decompensation, when he presents to the emergency, to the ER, or to the clinic with first symptom, and this is the initial diagnosis. We give him diuresis, we optimize his volume state, and we start the medical treatment. Then the stage C, what Dr. Fakhr will give us more details about how to invest in this time, how we can make the patient in better condition and optimize medical treatment, additional treatment like ICD, device, CRTD, more medication, and we try to help the patient to improve his symptoms, general condition, and prevent him to reaching to the last stage of the clinical course in heart failure, what we call it advanced heart failure. Advanced heart failure, if the patient reaches to this stage, that means you will see the patient every few months in your ER or in the clinic. He's symptomatic. He's near class 3 to 4, recurrent admission. He requires some inotropes. He starts to have some end organ damage, like renal and liver failure. And at the end, if we don't, this is the time to evaluate the patient for advanced therapy like LVAD transplant. If not improved, that means he is going to the mortality or palliative care. So advanced heart failure, heart failure in general, this is one of the disease with high prevalence, high mortality, causing other organ damage like renal, liver failure, recurrent hospitalization. So is making burden in health care system in general, and burden on the patient himself by poor quality of life and recurrent admission, nutritional and frailty, and most of the patients, especially if they reach the advanced heart failure, they will have some depression degree from mild to severe depression, and increase for sure the healthcare cost. And if you think the estimation in general in the world for heart failure, how is cost in all his life, is more than $85,000. That's estimate more than 300,000 riyal in Saudi Arabia. And if you think what we are doing usually in the clinic, giving medication, imaging, visiting, and this is the cost, actually the main cost is not coming from that. The main cost of the heart failure coming from hospitalization. And this is dependent on United States data, European, and even in Saudi Arabia and Middle East, almost 70 to 80% from the cost in heart failure coming from hospitalization. And even if we reach to the palliative stage, if we think the cancer patient, they are the main population who is dealing with the palliative cases. Actually, this is trial mentioned in general heart failure is almost more than the oncology patient. We are dealing almost more than 38% of the patient who reach the palliative stage in general disease is coming from heart failure and advanced heart failure. So this is the summary what Dr. Fakhr mentioned about how we need to prevent patient to reach to the advanced stage with investment more in optimizing his medical treatment, starting with the first stage of give him the 4 pills and maximize the medication, reassessment and additional treatment like device, CRTD, ICD, more medication treatment additional. And if patient is not improved, he is going to the stage D and advanced heart failure and will be referred to for evaluation. Actually, what I will add is not only optimizing medical treatment is the important in heart failure in general, is the time. Time in heart failure is against the patient. If you start the medication on the 4 pills with a small dose and you will maximize him after 1 year, I will tell you all the system, what we are targeting to the inhibit, the RAS system, the sympathetic system is still active. So the patient, he will continue with the same prognosis and will be reached to the advanced stage and earlier. So the guideline, depending on the many trials, they mention if you start the antiviral treatment, you should, class 1, you should maximize him within 6 weeks only. So we are talking about 1.5 months to give the patient the optimal and maximum treatment to reach the best outcome, best management. So early optimization of guideline medical treatment, actually we can achieve the reduction of mortality, readmission, quality of life improvement, and guideline medical titration and patient satisfaction and cost effectiveness. And how we can do this one? Actually, if we need to do all this one within 6 weeks, that means you need to see the patient early. After discharge, within 1 week, you should see the patient and evaluate his volume status, give him the maximum medication, repeat the renal function, increase or decrease the diuresis, and increase the antiviral treatment. And after this first visit, you need also to see him at least 2 to 3 times to maximize his medical treatment to reach the optimal stage. And not only that, this patient, he needs education. Education in heart failure is very important, to give him comprehensive education about the diet, about the food, about the medication. Otherwise, the adherence is very difficult in heart failure. And early intervention also by frequent visit to adjust his medication and additional treatment like ICD, CRTD, MV, CLIP, and early referral to advanced therapy for the patient will be good also. Actually, this requirement, if we will go to our practice, is very challengeable. We know how we are crowded, how is the volume of the patient, how is the challenges of manpower. Actually, the main challenge is the physician number. Cardiologist is low, and the heart failure cardiologist maybe is lower number. You need not only the clinic, the people who is running the clinic, they should know the challenges and limitation and how they can optimize the patient with clear pathway and experience. After all this one, we know the high volume of the patient visiting the patient. Some of the clinic reach more than 20 to 30 patients per one clinic. So limitation of availability, visit and appointment to the patient within 1 week, and frequent at least 3 to 4 appointment within 1 month is very challengeable and very difficult to achieve this one in the practice. And after all this one, I need to sit with the old patient to give him full education at least for 15 to 30 minutes to give him full education about the heart failure. So practically, what we are doing, if we'll see the patient, and after the first diagnosis, usually the first slot for the patient to be seen in the clinic after 3 to 6 months, and patient will be maximized maybe 1 year. This is the usual practice, what's happened. So in general, what's the solution now for this one? If we will not give this patient the optimal medication, optimal management and early optimization, that means just we are giving, and at the end, many of the patients, we are losing them without early optimization. So one of the solutions is coming, the clinic called Heart Failure Transitional Clinic. And this is clinic mainly led by heart failure nurse. So heart failure nurse will be trained for some time in heart failure medication and assessment and evaluation from the volume status of the patient, and she will run the clinic, and she will follow the patient actually or virtually. And the main advantage of this clinic, after the discharge of the patient from the first diagnosis, the patient will be seen within 1 week usually, and will be optimized within 6 weeks from all the advanced management or additional treatment or referral. And after all this one, the patient, after 1 to 3 months, will be discharged from the clinic. So they will not keep the patient with them at all. They will send him again to his primary consultant after 3 months to be seen with optimal medical treatment. So keeping this pathway of additional patient to this clinic and discharge from the clinic, it will keep the patient, keep the number of the clinic, the patient in the clinic in the average number without crowding the patient. So the main target of this heart failure nurse clinic work is to early intervention by seeing the patient early and additional monitor of the patient, see them more frequently, optimize them. They can give the patient, as the clinic will not have big number of patients, almost around 10 patients, 8 to 10 patients per visit. So they can give the patient comprehensive education about the food, about the diet, daily weight, how they can recognize the early signs of heart failure decompensation, medication, recognition, and reconciliation. They will sit with the patient with each medication and how they can optimize it, and up titration, and actually structural follow-up, and they can even monitor the patient not only from the clinic, even by the phone, even through the remote monitoring. And the most advantage of this clinic I saw, actually more than physician, that they can work as care coordination. Care coordination, that means they are the central coordinator with the other health care provider. They can connect the patient with early appointment with the pharmacist, dietitian, social worker, and other specialty. I think there is a problem here. Go back. Okay. So the benefit and outcome, the main benefit of this clinic actually from all multi-trial systemic review and meta-analysis for almost more than 10 years now, and more than this one for sure, is targeting to decrease heart failure readmission, hospitalization, improve the patient quality of life, and optimize the up-titration of guideline medical treatment, patient satisfaction, and cost effectiveness. This is I will have quick review about what we have data and trials and meta-analysis systemic review on this topic. The benefit coming initially from early optimization, as we say, and medication optimization in heart failure. They compare in this systemic review the usual care, what we are doing, comparing to the transitional clinic leading by the nurse, and they found actually the patient is more early optimized. And not only this one, even the number of dose of optimization from ACE inhibitor, for example, and beta blocker is greater. They are greater dose, so they achieve the target more than the regular routine clinic visit. For sure, if they can optimize them early, they have effectiveness on readmission. And this is meta-analysis and systemic review assessing the patient from decreased hospitalization and decreased ER visit with significant improvement and reduction comparing to the regular and routine and regular care or usual care. From quality of life also, this is also the recent trial assessing it's randomizing trial including 192 patients from Canada, which shows significant improved quality of life in this program more than the usual traditional program. And for sure, if you will decrease hospitalization, you will have cost effectiveness. So they have many evidence and trial. There is variation between benefit and no benefit, but actually they have many big trials and many systemic reviews show there is cost effectiveness from transitional clinic that leading to heart failure and decrease the hospitalization. So in King Fahd Medical City in Riyadh, we have experience and it's built this experience over many years with heart failure outpatient services in general, including the clinic running by the heart failure nurse practitioner. They are expert almost now more than 8 years. They are running their clinic with including more than 2,000 patients in this clinic per year. They are optimizing the patient within 1 to 3 months and discharge to the cardiology clinic. They have other services like diuresis in outpatient, so they can prevent, even if the patient is not improved with the initial management, they can give him the service as an outpatient. And from telehealth, they can monitor the patient with many, starting from the phone call, WhatsApp call, to more advanced of non-invasive like Apple Watch, to more invasive like pulmonary artery sensor, the CardioMEMS, and advanced, they are involved in the advanced heart failure program like LVAD and transplant. Not only that, they reach more than this point and provide training and service to other centers. They include many centers from north, south, west, and they train the nurse from other centers to establish the service there. So they have, we have already heart failure nurse practitioner who is qualified not only for the heart failure, even for train the other people from the Saudi committee. And we have good experience, alhamdulillah, almost include 5 centers now in this training program. So in conclusion, comparing to the usual care, the nurse lead the traditional service to the heart failure patient. Actually, they have big trial and minimal multi and systemic review showing this significant heart failure readmission decrease and improve the patient quality of life and guideline medical treatment titration and cost effectiveness. Thank you.
Thank you very much, Dr. Fahmi, for this nice lecture about innovative program that will help us, inshallah, in the future in our city. Now, without further ado, we have our الضيف العزيز البروف أحمد الهرسي. He will talk about novel devices in ICD, extravascular devices. هو البروف هرسي غني عن التعريف، أستاذ قدير في جامعة الملك سعود، وتشرفت إن كنت أحد تلاميذه في فترة من الفترات. appreciate his coming to حائل and welcome Dr. Hirsi.
طيب السلام عليكم ورحمة الله. Good afternoon, ladies and gentlemen, and very thankful for the invitation. And I promised Dr. Wael Geshkari to keep it simple for the interventional cardiologist and straightforward. So I was tasked to talk to you about the advances in electrophysiology, namely extravascular ICD, a promising novel device. So this just to show you I'm equally conflicted. So put everything I say in this context. The objective of today's talk is to take you through a journey of how ICD implantation has evolved from the very well-known established intravascular ICD to the subcutaneous ICD to the extravascular ICD, and the most important thing to answer why. Why did this revolution and evolution happen in the industry, as well as the evidence. I will talk about the comparisons between subcutaneous ICD and TV ICD, which is transvenous ICD. Then I'll talk about the EV ICD studies and how does the future look like. This is the first transvenous ICD, or the first ICD was implanted in 1980. And at that time, it required cracking the chest. So open heart surgery, put a patch on the ventricle, sew the patch to the ventricle and close the chest. That was 1980. In 1988 was the first intravenous ICD implantation. And then in 1993 was the FDA approval of this methodology based on the evidence that accumulated over the years as an approved as the way to go to implant ICD. So for the intervention cardiologist, we go through the jugular vein sometime. No, that's not jugular vein, صح? Wael? So this is the subclavian or the axillary vein. And we put the lead in the ventricle. So that's the beauty of this procedure. So when you have the lead in the ventricle, you have a clear sensing, clear detection of the arrhythmia. You require less joules to shock the ventricle in case it's a VF or a VT. And along the years, over the last 30 or 40 years, the evidence has evolved, the technology has evolved, the size of the device has become smaller, the battery longevity has improved quite significantly, and the feature has improved, as well as the population is studied, and the timing of the LV dysfunction, whether it's post-MI right away or 3 months post-MI, has been accumulated. So if you look at the bottom of the slide, there's multiple randomized clinical trials, which give us confidence that this procedure or this indication or this intervention does save life. And in EP, unlike our colleague intervention, we use hard endpoints. We use one single endpoint, either death or arrhythmic death. We don't use composite endpoints. You can look at it, whether you look at the primary prevention or secondary prevention, ICD saves lives, no doubt. So the question comes, why bother, why change? Why change from something that's working robustly, has a very strong evidence, and change the way to implant this device? And the reason is, along the years, there has been accumulating retrospective studies and evidence suggesting that having a lead inside the heart can be detrimental in terms of development of heart failure, tricuspid regurg, worsening or development of new tricuspid regurg, as well as death. And the nightmare of electrophysiologists when you have a lead that's 4 or 5 years or 6 years old and then develop infection. So to go and take that out, this is associated with high risk of mortality. The trial that is shown added a very significant body of evidence to what we already know, but this time it established causality. So we know that having a right ventricular lead, although it's important, and it's very important because you can detect the arrhythmia, you can have less joule to cardiovert, but it can have its own challenges and risks. This is Dr. Naif Al-Ghassab with his colleague for the first time shows that this is a causality relationship. So the lead can cause tricuspid regurg. The lead can cause RV dysfunction. The previous knowledge has been accumulating from retrospective historical data, but now in RCT shows that this is a causal relationship. And the second most important thing from this trial is that this can happen as early as 6 months post-implantation. So those are the two main reasons that led us to think about other venues or other places where to put this lead. So this is the second approach to avoid and solve for this challenge, which is having a lead inside the ventricle, is to go extravascular. And the first trial that is being done, it was done in 2010 maybe. It was very robust studies, but the most important trial was done in 2020, which was a randomized head-to-head to transvenous ICD. This study was, subcutaneous ICD was approved in 2012. The first subcutaneous ICD in Saudi was in 2014. So we go, in this case, above the sternum, so not inside this, above the sternum, and we put the device subcutaneously, which means you need more joules to shock the heart. You need a bigger device with a bigger battery, hopefully to help with that. This is the pivotal trial. So the first question, does it work as good as the transvenous system? And the answer is yes. This is a head-to-head comparison, looking at efficacy and performance, and yes, indeed, subcutaneous ICD is as good as, in terms of performance, to the subcutaneous ICD. The question at hand, is it safer than transvenous ICD? And indeed, the answer is yes. Having a lead outside the heart, it's safer. So lead-related complication is less with subcutaneous ICD. Device-related complication is less. So kudos for subcutaneous ICD. We solve the problem. We get rid of the main issue that we had been dealing with for years. This is the conclusion of the randomized clinical trial, that subcutaneous ICD is comparable in performance to transvenous ICD. It's similar in device-related complication, but the most important thing that it was solving for is the lead-related complication, and subcutaneous ICD has proven without doubt that it has lower lead-related complication when it compared to transvenous ICD. Fewer serious infections required extraction in subcutaneous ICD because it's extracardiac, right? So you don't worry about vegetation, you don't worry about serious septicemia and septic shock or thromboembolic events. The evidence accumulated over the years, this is the meta-analysis of randomized and non-randomized studies, 13 of them, 9,000 of them, 9,000 patients. 70% had implantation for the reason of primary prevention, 44 in ischemic cardiomyopathy, and 46 in non-ischemic. And the answer is the same as the pivotal trial. Subcutaneous ICD, with all these studies have shown and proven it is as effective, as good as transvenous ICD. Furthermore, if you just look at the randomized trials or the studies that use propensity score matching, which is a more robust way to look at the evidence, again, it shows that device-related complication is less with subcutaneous ICD. lead-related complication is less with subcutaneous ICD than transvenous ICD. So in conclusion for this part of the talk, subcutaneous ICD prevents sudden death, as good as transvenous ICD. Groundbreaking lead safety with subcutaneous ICD, but the problem is, we solved for one problem, we created other problems. Subcutaneous ICD is big in terms of size. It's really big, as opposed to the small 30 cc transvenous ICD, number one. Number two, because you are extravascular, you're above the sternum, you need larger joules to shock the heart. So in transvenous, you need 30 joules, 20 joules sometime. Here we're talking about 80 joules, which means less battery longevity and less comfort for the patient. So the quality of the life of the patient has been compromised with these devices. So we solved one problem, but we created another problem with subcutaneous ICD. Here is the answer to all these problems. So you can think about EV-ICD or extravascular ICD as the holy grail. It combines the beauty and the features of transvenous ICD, the small size, all the parameters, the ATP, the programmability, the pacing function, all the functionality that developed over decades for transvenous ICD, plus the beauty of having the lead outside the heart, as we seen in subcutaneous ICD. So what the device goes under the armpit. It's very small, barely you can see it, and the lead goes under the sternum, so it touches the heart. So we come full circle. We started with a patch with a cracking the chest and putting the lead on the heart, and now we go and take another route and we put the lead on the heart exactly, but under the sternum. This is the pivotal trial. We were really glad to be part of the pivotal trial. The FDA approved the EV-ICD in 2023. The trial ran from 2019 till 2022. Our center was one of the centers that enrolled patients in this trial. It was the first in man and the first in man in MENA region, so we're really proud of that. This is the trial sites. There was 46 sites globally, 17 countries, 55 implanter, and the FDA granted approval based on this piece of evidence. The trial excluded patients with prior sternotomy for obvious reason, because they have a very narrow mediastinal area, because you need to have a good space between the heart as well as the sternum. But with post-sternotomy, that area becomes very narrow and the space becomes really challenging. Chronic pacing indication for CRT were excluded patients who had unstable or undergo defibrillation testing. This shows the cohort that were studied in this study. So you can include or included primary prevention, secondary prevention, patients with channelopathy, male and female, younger populations, and EF less than 30%. So in other words, all your patients that need an indication for transvenous ICD can be a candidate for EV-ICD, except if they had sternotomy. This shows the efficacy of and the safety of the EV-ICD, and without doubt, because it's exactly the same device, exactly the same battery as transvenous ICD, so we expect to be as effective as the transvenous ICD. This shows the long-term safety, 18-month safety, still maintains low risk of complication and same efficacy in the pivotal trial. This is 3 years safety profile of the procedure, and without doubt, this has been proven to be extremely the way to go in the future. This is the global outlook of implantation of devices until 2032. And as you can see, in 2022 to 2023, 42% of the market share of ICD implantation was subcutaneous ICD. And I would expect over the years, EV-ICD will gain also more market shares, and that will be the future and the way to go. Ladies and gentlemen, in conclusion, subcutaneous ICD is superior to transvenous ICD in preventing lead-related and associated complication. EV-ICD is as effective as transvenous ICD, and it's also shown effectiveness in 3 years time period. the incidence of major system and procedure-related complications is very low, extremely low with EV-ICD, and globally the rate of subcutaneous and EV-ICD implantation is increasing. Thank you so much. Question from interventionist, wow.
Yeah. So, first of all, thank you for this wonderful lecture. What do you think the percent of patient who can receive the subcutaneous device, from the general population which with ICD indication? I think the heart failure patients are cachected and wasted, and I don't know if this large, it's going to be comfortable for them, the device. So, in your estimation, let's say that we 100% transvascular ICD from this 100% or this number, how many of them they can accommodate the extravascular?
So I think the whole field is moving to more extravascular, whether subcutaneous or EV-ICD.
Yeah.
But there is still some, especially if the patient is young, in young people who need primary prevention, who might need in the future lead revision or multiple devices. The way to go, for in our center at least, is to go extravascular, either subcutaneous or EV-ICD. In patient with, at this point in time, post-CABG, if you want to go extravascular, your only option would be subcutaneous ICD, not EV-ICD by indication. But I can foresee the majority of implantation would be extravascular in the future.
Thank you. Dr. Ibrahim, just a quick question, okay, to the...
I'm really glad that they get interested in intervention cardiologist. تفضل تفضل.
للدكتورة. What about the Digoxin now? We hear from, the European Society of Cardiology, they presented a paper, that the Digoxin again is revived. So where we can put it in the guidelines, which patient they're going to benefit from the Digoxin? Yes.
Dr. Wael, this is a very complex question, maybe. إذا في 1 minute ما في.
أيوه كده واضح الصوت. دكتور وائل, Digoxin, you're asking about Digoxin? Well, this is a topic by itself, but again, Digoxin is part in our heart failure guideline for Saudi Arabia, especially for patients who we are controlling the rate for them rather than the rhythm, and they're not responding to the other medications like beta blockers. But it's part of the guideline in Saudi Arabia, even globally. But again, we shy away because we have certain criteria for the patient, and also the morbidity and mortality has not improved with these medications.
The paper presented at the European Society of Cardiology shows some, I think, mortality or benefit, or?
In regard to the recent publication, yes, I think the Digoxin shows even not reduction of hospitalization, but reduction in death as well.
So we'll keep the question to the end, then we can discuss with our esteemed speaker. Last topic presentation in this session will be about role of potassium lowering agent in ratio optimization in patient with heart failure. Our senior clinical pharmacist, Dr. Ali, is board certified in cardiology pharmaceutical, and he's the leader of pharmaceutical service in Hyel cluster.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good afternoon, everyone. Thanks, Dr. Halim, for your introduction. I would like to take this opportunity to thank the scientific committee for inviting me to this very important topic in our daily practice. Thanks as well for AstraZeneca for sponsoring this session. So today, this is my disclosure. Starting with, I would like to start with just short story from our daily practice in the clinic. This is one patient. came to our clinic. Let's call him Halim, not our Halim. So Mr. Halim is a 72 years old male, known case of heart failure with reduced ejection fraction, CKD stage 3B, type 2 diabetes mellitus. He hospitalized 6 months ago for acute decompensated heart failure. His current medication are Entresto 100 mg BID, furosemide 20 mg OD, empagliflozin 10 mg OD, bisoprolol 5 mg OD, and his last blood pressure 138/82, and last potassium was 5.1. So this is regular story of a regular patient came to our clinic. We all know the evidence, and we all know he should be on full dose of Entresto. We know he is a great candidate for aldosterone receptor antagonists such as spironolactone, a drug that would significantly reduce his risk of admission, mortality, and extra. The discussion usually between us and the patient, well, Mr. Shamsan, your potassium is already a little high. So this is screen is off. So if we add another medication, it could push your potassium into a danger zone. So let's play it safe, hold off for now, repeat your labs in next appointment, and we will see. This is regular scenario happens in the clinic. Let's play it safe. How many times have we all said that? We choose inaction over optimal action. We accept a suboptimal outcome because we afraid a potential adverse event. We created the gap, the treatment gap of RASI, and Mr. Halim fell right into it. So today we are going to talk about how to close this gap. We are going to reframe our thinking. We are going to move from being forced to withdraw therapy to proactively enabling it. The title of this lecture is not just about managing potassium, it's about unlocking RASI full potential. So starting with the incidence and risk factors. Almost in CKD patient, the hyperkalemia is reached up to 50%. In heart failure patient, the hyperkalemia reached up to 30%. And in hemodialysis, hyperkalemia reached up to 25%. So despite overwhelming evidence, RASI remains chronically underdosed. We know that, underprescribed in our heart failure and CKD patient. Why? The single biggest barrier, as we mentioned before, the fear of hyperkalemia. So hyperkalemia is recurrent. In this published based cohort linking individual data from mandatory hospital prescription and laboratory database in northern Denmark that was published in 2018, they screen 1.8 million starting from 2000 to 2012. The recurrent of hyperkalemia started after diagnosis of heart failure, reached 39% within the first 4 months. The next up to 6.2 months, they reached the second event of hyperkalemia up to 43%. Then they as well experienced the third hyperkalemia event up to 54%, and the fourth hyperkalemia event up to 60%. So, as we mentioned, the 6-month hospitalization risk after index date was 2.8 higher for heart failure patient and 3.8 higher in CKD patient compared to matched patient with heart failure CKD without hyperkalemia. So the mortality in those patients, the recurrent hyperkalemia is associated with increased mortality in a heart failure subgroup of patients with CKD up to 30%, all cause of mortality. And in subgroup, higher risk of all cause of mortality compared to matched patient without hyperkalemia. Consistent results were seen in RASI treated patients. As well, in this comparison, in this retrospective analysis of medical record from USA, they compared the heart failure patient, diabetic patient with the control group. The control group involved individuals without heart failure, without CKD, without diabetes, any cardiovascular disease, nor hypertension. So hyperkalemia associated mortality is higher with these comorbidity. RASI dilemma. Mortality approximately 2-fold higher for heart failure patient. So the fear of hyperkalemia may be responsible for more deaths than hyperkalemia itself. RASI dose reduction as well is not recommended, is just as harmful as RASI discontinuation, both associated with doubling mortality. Its reach in end-stage kidney disease and heart failure related hospitalization up to 51% with RASI dosing reduction and 55% with RASI discontinuation compared to the risk with RASI maintenance. So, and this is not just CKD issue for sure. Look at the data from HFrEF registries, a lot of registries. Despite being a class 1 recommendation for over 2 decades, we are failing to get spironolactone to target dose in over 85% of our heart failure patients. Again, hyperkalemia is a dominant barrier. So, as well, heart failure subgroup showed increased morbidity risk with RASI down titration or discontinuation following hyperkalemia. The risk of heart failure related hospitalization reached up to 43% increase with RASI discontinuation and up to 40% increased risk with RASI dose titration. So what about the treatment, the previous treatment and the current treatment? In the previous treatment, we have several limitations. In regard to the low potassium diet, so because it's difficult to adhere, most of patients, they have difficult to adhere to. Limiting potassium-rich food can cause GI problems such as constipation as well. Diuretics efficacy depends on residual renal function as well. The discontinuation or a dose reduction of RASI therapy, it's not a solution. The traditional potassium binder, for example, CBS or SBS, no consistent actually evidence for its efficacy, and the side effects is documented and well known. What about the new treatments? We have sodium zaccharium, Betyromere, and calcium rhizanium. In regard, this comparison is not based on a head-to-head comparison, but based on each properties for each molecule. In regard to mechanism of action, the sodium zaccharium, the one who has high selectivity in comparison to Betyromere and calcium rhizanium. The onset of action was rapid with the sodium zaccharium and variable with calcium rhizanium, reached 2 to 12 hours, while in Betyromere delayed onset up to 7 hours. The indicated for hemodialysis patient only with sodium zaccharium, and the guidelines recommendation goes for sodium zaccharium and Betyromere. The drug-drug interaction, the better molecule in regard to the drug-drug interaction is sodium zaccharium, since it may be taken with most of other medication. Limited exceptions with pH dependent drugs, we could separate the medication 2 hours between each other. And in regard to safety profile, sodium zaccharium shows edema up to 5 to 7%, mainly with a specific dose which is not registered in the GCC countries, which is 15 gram, and hypokalemia 4.1. In Betyromere and the calcium rhizanium, the metabolic and GI disorder and hypomagnesemia as well as a side effect. The administration, the easiest molecule to be administered since it can be taken with or without food, is the sodium zaccharium. In regard to its doses of sodium zaccharium, we have two phases, the correction phase and the maintenance phase, especially for the acute hyperkalemia cases. We can give 2 sachets of 5 gram 3 times per day until 48 hours until normal kalemia is achieved. If not achieved within 48 hours, we can also give another 1 day trial. And in maintenance phase, we give 5 gram sachet 1 times per day. In regard to guidelines with RASI therapy for cardiorenal patients, for patients with HFrEF, AC or ARBs and aldosterone receptor antagonists are recommended to reduce, as we know, risk of heart failure, hospitalization and death. So RASI also improves symptom and slow the EGFR. As well in CKD patient, ACE or ARBs are recommended to reduce the risk of CKD progression, kidney failure, cardiovascular event and cardiovascular death. Because RASI therapy increases hyperkalemia risk, guidelines state that potassium level should be monitored in patients on RASI. What the Europe Society of Cardiology guidelines support use of potassium binder, or when they support the use of potassium binder in patients with chronic or recurrent hyperkalemia on RASI therapy, and approved potassium lowering agent may be used, either Betyromere or sodium zaccharium, initiated as soon as potassium level are confirmed as more than 5. And why? Because the administration of potassium lowering agents such as sodium zaccharium or Betyromere may allow RASI initiation or uptitration in large proportion of patients. The Saudi Heart Association as well, they give one recommendation with preference for sodium zaccharium in acute setting. So potassium binder may be used before RASI optimization or discontinuation, so you have to give a trial. Sodium zaccharium has advantage in acute hyperkalemia due to its more rapid reduction of serum potassium. And in regard to different guidelines, different international, national guidelines, they emphasis on the role of potassium binder in optimizing RASI. Europe Society of Cardiology, they release a guideline and it's mentioned that, and in the American College of Cardiology, American Heart Association, American Heart Failure Society of America as well, KDIGO guideline for CKD, and the NICE gives a special, the screen is not working, the NICE give guidelines recommendation for sodium zirconium for treating acute life-threatening hyperkalemia as the Saudi Heart Association do. In regard to KDIGO guideline, they give comparison between these molecules, the only non-resin, non-polymer, the selective potassium binder was the sodium zirconium, as well the only potassium lowering agent selective to potassium only, and most rapid onset of action within 1 hour, and only potassium binder that can be taken with or without food and with other medication only. The final take-home messages, I think it's good with time. The goal is not just normal potassium level. This is the message that we should emphasize on. The goal is maximizing RASI inhibition to save kidney and heart. With modern potassium binder, we can now treat the lab value to save the patient, rather than sacrificing the patient to treat the lab value. By integrating these strategies into our practices, we can finally close the RASI treatment gap and provide our patient with the full benefit of GDMT. Thank you.
Thank you, Dr. Ali. Due to limitation of time, we will conclude this session, and our guest can approach our speaker during the break. We will have 10 minutes break before we start the other session. Thank you all. دكتور فخر الأيوبي. فاهم دكتور علي التبناوي. We will gather after 10 minutes. We can go for prayer and some refreshing foods.
a group 1 pulmonary hypertension, then you fast track them to a high expert center. If there are no features of if there are features of left heart or lung disease, then you just continue the screening and the workup. VQ scan, additional testing like CT scans are recommended, and finally, right heart catheterization is the way to diagnose the disease. A new concept, although it's not very new, like it's not 100% new, but it evolved over the years, is the concept of risk stratification. And I believe this concept should be applicable to all medical problems that we deal with. So basically, one shoes does not fit all, and that's the same for patients with pulmonary hypertension. Basically, and it's not the purpose of this slide to just go over the details, but when we see patients with pulmonary hypertension in the first time, we try to categorize them into either low risk, intermediate risk, or high risk based on multiple different variables. So we have clinical, exercise, biomarkers, imaging, and right heart cath data. And we try to see where is our patient fit in this category. Not only that, this is the first time we see the patient, but when we see them and we start them on medication, we see them in 3 months after starting medications, we try to risk stratify them again to help us understand what is the best treatment algorithm for those patients. And again, this next time we use lesser variables, so we only depend on clinical 6-minute walk or exercise function and BNP to help us put our patient in one of these 4 categories. And based on that, we choose what is the best medications. So medical therapy for PH constitutes 4 different pathways. We have 3 pathways that are basically looking at the imbalance between vasoconstriction, vasodilatation. Those are the endothelin pathway, nitric oxide pathway, and prostacyclin pathway. And more recently, in the last 2 or 3 years, we now have a new pathway which looks at the disease from a different perspective. So it looks at the, as we said, there's increased proliferation, decreased anti-proliferation in patients with PH in a way that is similar to cancer. There is, and this pathway, new pathway, basically inhibits this tendency to proliferate in the pulmonary vessels. So this is a new medication called sotatercept that we have now in addition to our traditional medications. So this is the list of medications that have been invented since the 1990s, and you can see that over the years we have accumulated multiple different medications from different pathways. What's missing from this slide is selexipag, which is an oral prostacyclin agonist, and also sotatercept, which is the new medication as I just described. So selexipag, which is an oral prostanoid receptor agonist, was shown to be superior to placebo when it was given to patients with PAH who are already on dual PH therapies. So this is an additional therapy, and it improves exercise capacity. And the same thing with sotatercept. We have now multiple publications showing that it is also useful in improving exercise capacity on those patients who are really symptomatic. Remember, we're talking about patients in their 20s and their 30s, so any additional ability to do things in their daily living is really welcome, even if it didn't lead to change in mortality. Now, this is the recommended treatment algorithm. When we start the patient in the first time, we divide them into either high risk or low risk, and based on that, we give them the cocktail of medications, and we do the same thing again at 3 or 4 months. We try to risk stratify them and then fine-tune that cocktail of medications based on the patient's needs. Moving on to other new developments in patients with pulmonary hypertension, although this is not still endorsed by the guidelines, but there is, in similar concepts to renal artery denervation, we now have works done in pulmonary arteries to see if we can denervate the pulmonary trunk, and hopefully by that we can restore the balance between the vasoconstriction and the vasodilatation. So we know that the main pathogenesis of PAH is that vasoconstriction activity is more than the vasodilation activities, and when we and this is most of the time is related to overstimulation of the sympathetic nervous system. And the idea of PADN was actually derived from the success work and the renal artery denervation. So basically, this is a device, and you can see that the catheter has a circular shape at the end, and you go to the pulmonary trunk and you try to apply the pulses at different locations. And there have been good work suggesting that this may be something that we can consider in the future for our patients with pulmonary hypertension. Moving on to patients with CTEPH, chronic thromboembolic pulmonary hypertension, it used to be the case that the treatment of choice is open heart surgery with pulmonary endarterectomy. This is a major surgery that requires hypothermic arrest, and it needs to be done in a highly specialized center. With time, we've noticed that not all patients are candidates for this procedure, and some of the patients actually have contraindication for open heart surgery, or they have residual disease after this procedure. So in the early 2000s, the Japanese physicians have innovated a new way of dealing with this dilemma by going in and ballooning the distal pulmonary vessels. As we can see here, you have in picture A, a lesion similar to the ones that we see in coronaries. Instead of putting stents in, which we don't, we just go and balloon them. And you can see at the right-hand picture that you can see how augmented the pulmonary flow is by just ballooning these constricted vessels. You do this procedure at multiple sessions. Probably patients will need 5 to 6 sessions to have complete improvement, and usually we see a significant hemodynamic response to these procedures. Of course, it's not without risk of complication. You can have perforation, you can have lung injury or reperfusion injuries, but with time, people have started to develop protocols to help alleviate these complications and to deal with them effectively. So in summary, recent advances in PH revolves around newer medications, newer procedures, and I think we still have room to help our patients in this regard. Thank you so much.
Thank you, Dr. Khudair, for this excellent presentation. So we will leave the questions all to the end. All the audiences will be here. So Dr. Khudair, you can come over here, please. So I will have the pleasure here to introduce our next speaker, Dr. Dania Moti. Dr. Dania is actually a professor of medicine from Limoges in France, and also she's a full consultant in the King Faisal Specialist Hospital in Riyadh. She has a long experience and special interest in heart failure, cardiomyopathy, echocardiography, and cardiac amyloidosis. So we were glad to have her here, and she will talk about cardiac amyloidosis. Thank you. تفضلي.
Assalamu alaikum. Good afternoon, everyone. It's my pleasure to be today here in Ha'il. I am very honored and happy. Thank you for the organizing committee for inviting me to this meeting. I hope the slide will be working a little bit stretched, but so this is my disclosure today. And I don't know, I have a question for you in Ha'il. How many cases of amyloidosis have you been diagnosed since a few years? Any cases? Proven free. Suspected. Classical. Actually, you are not far from the reality. That's what's happening in every center. And just to show you these cases, this case comes from Brigham Hospital, a big hospital in the United States in 2004. And actually, no single words were taken about this origin of HFpEF. So even big centers in 2004, they were missing the diagnosis of ITTR or cardiac amyloidosis. And you can see it now in 2025. If you can show you this case, you will be, all of you will be suspecting this case. So why it's difficult to diagnose amyloidosis? Because it can simulate many conditions, and the clinical manifestations are misleading and depend on the site of the amyloid deposit and the organ dysfunction. Cardiac involvement, unfortunately, has major prognostic impact on survival, and actually it occurs in more than 70% of the cases, depending on whether we're talking about wild type, light chain, or a mutant. The diagnosis, however, is not always straightforward, and it implies integrative approach, clinical clues, EKG, biomarkers, and echo, and sometimes MRI. Multimodality imaging is sometimes, and tissue biopsy are mandatory to reach the correct diagnosis. However, please remember that the best way to diagnose them is to think about the disease. If you don't think about the disease, you will not find them. So basically, just for those who would like to know exactly just what's amyloidosis, it's a group of disease actually, and the classification is made according to the nature of the fibril precursor protein, And so far, we have more than 40 precursor proteins capable of forming these amyloid fibrils in vivo. However, in our clinical practice, 98% of the amyloid heart disease are either due to light chain amyloidosis or ATTR types. So this is at the left side, you can see in blue the TTR amyloidosis, which can be hereditary or acquired. Both of them are due to deposit of abnormal transthyretin protein, which give organ dysfunction according to where the deposit will be. On the other side, you have the light chain, which is deposition of light chain due to plasma cell dysplasia. I will not talk today about it, but you have to know that it's an urgent disease. And of course, you have other type of amyloidosis are very rare, such as apolipoprotein A, heavy chain, gelzosine, or all of these. So just how it forms, you can see, I will not talk again about light chain, but just to remember you that transthyretin is a normal protein. We call it before pre-albumin. And actually, it's produced in the liver as a tetrameric protein. It's a tetramer, but it transports the thyroxine and the retinol in the blood. So basically, this tetramer, under certain condition, oxidative stress, unluck, bad luck, or something, or mutation, can dissociate into monomer subunit. The monomer cannot stay on the blood like this. It's exactly the light chain are toxic and they cannot stay. So what happens for the monomer, they misfold and reaggregate into toxic dimers and oligomers to form the insoluble amyloid fibrils. And these amyloid fibrils are deposited extracellularly in the interstitial space of the myocardium. So really, this is the main things that we should know about this amyloid, basically. But remember, because I have some cases missed, all cardiac amyloids are not ATTR cardiomyopathy. Roughly 50% of the one you were diagnosed before 60 years are light chain, and this is really, really very, very severe disease and fatal. And the light chain is an acute and need urgent diagnosis and treatment. So now, coming back to the ATTR, this is just a slide to show you that we have, regarding the ATTR, the mutant one, we have more than 120 mutation of TTR gene on chromosome 18 already described at the autosomal dominant with variable penetrance. Remember, the age of onset could be third or fifth decade. Usually it comes on the neuropathies, then it comes to a cardiomyopathy after 5 to 10 years. However, depending on the mutation, you can have predominant neurological phenotype or predominant cardiac, such as the American one, the val isoleucine 142, or mixed phenotype, which could occur at, as I told you, around 40 years or 50 years. Mixed phenotype means they have the cardiomyopathy and neuropathy at the same time. So if you have someone who's presenting with unexplained neuropathy, unexplained cardiomyopathy on the same time, and he has some future and red flags, please think of amyloidosis ATTR mutant, okay? Now, the good news, next please, the good news about this one, so if you diagnose one case, you will diagnose the whole family. And God knows how big are our families in Saudi Arabia. We have one family, and so far we have at least 7 cases diagnosed from the same family. Okay, especially if it's the father and he get married with several wives, so we'll have so many kids, and it's autosomal dominant, okay? So basically just the problem of ATTR until now, remember what Dr. Halim told you, only 3 cases. However, in all other the planet, they have a lot of cases because the disease awareness comes much earlier. When I was in France in 2007, we started already making a lot of diagnosis. So we came a little bit late on Saudi Arabia. So it's underdiagnosed and contribute to significant delay in diagnosis. Basically, remember that the mean time to diagnosis around 3 to 4 years for the ATTR neuropathy, 5 to 15 years the survival, and it's irreversible if we don't diagnose it with a loss of quality of life. For the ATTR cardiomyopathy, the mean time is around 6 years. It's a long time, okay? But once you diagnose it, if you don't treat it, the median survival is around 4 years. Remember, 4 to 6 years for ATTR cardiomyopathy and 4 to 6 months for the light chain if you don't diagnose it. So really, it's applied a lot of things. Just to remember you that this is kind of all the extracardiac clinical signs. Of course, there are more of them, but this is very obvious when you have somebody with purpura, when you have somebody with macroglossia, when you have somebody with a soft tissue lesion. This is more likely to be associated with light chain. On the other side, when you have musculoskeletal manifestations such as carpal tunnel syndrome, deltoid hypertrophy, biceps tendon rupture, it's more likely to be associated with ATTR. And if you have orthostatic hypotension and you have peripheral neuropathy that is symmetric and peripheral, remember that it would be both. So this is really our red flags for us as echocardiographer. This is again from paper from Jack showing you that Up to 80% of the patient with hereditary ATTR will have mixed phenotype, mixed presentation. In addition to the polyneuropathy and the cardiomyopathy, you will have musculoskeletal such as carpal tunnel syndrome, shoulder knee pain, trigger fingers, numbness, all the things. And the autonomic dysfunction is very obvious when somebody has hypertension and suddenly he becomes hypotensive and he stopped by himself the medication. So these are really red flags for you. And of course, from the cardiac point of view, a little bit usually it's late, but you have 50% of them, they have atrial fibrillation, they have arrhythmia, bradyarrhythmia, first AV block, because of the deposit everywhere. And of course, the LV thickness more than 12 usually. So really, we need an aggressive screening, and I show you already this presentation before, screening of the cardiac amyloidosis everywhere in the high-risk population. Where? On the HOCM clinic, on the aortic stenosis clinic, on the TAVI population, on the HFpEF population, even HFrEF and HFmEF when they come late, and also in the clinic of the carpal tunnel syndrome, more than 7% of the patient, and sometimes in incidental findings by bone scintigraphy for somebody coming for a cancer or something. So all this one should, of course, the multiple myeloma clinic are also a big one to screen a light chain amyloidosis. Again, I'm talking about that. Now, the identification of patient require a combination of different approach. As I told you, clinical examination, clinical symptoms, EKG analysis, echo analysis together. Not only one will give you the diagnosis. Now, we are lucky because we have also artificial intelligence that is assisting us. Hopefully we'll have it in Saudi Arabia soon. I'm trying to work with the administration to see how we can, because I'm sure we are missing a lot of patients exactly like here and we're not finding them. So if we put artificial intelligence AI in the echo machine or in the EKG, we'll find many misdiagnosed that was mandridden. And all of this should be supported by medical education, training, awareness, and working with expert center in diagnosing and management. Okay, now just to show you, I will not go details, the main EKG flag, remember, pseudo-infarct pattern with no obvious coronary artery disease, absolute or relative QRS voltage. Don't wait on the absolute relative voltage, and of course, all the unexpected conduction abnormalities and atrial abnormalities, okay? Today, I will not talk really about everything because it's an overview about things. In our experience, echo is the best pathway to diagnose and to suspect amyloidosis when it comes to combine to EKG and biomarkers. I don't know why the images are not moving here. It should move, sorry. Anyway, for some reason they are not moving, but it's okay. You can see it, and it's obvious with the 4-chamber view and the other one. But the most striking recording as comparing to the hypertrophic cardiomyopathy, the HOCM one, you can see the longitudinal destruction of the MAPC, the destruction of the longitudinal function, S prime very low, at the lateral level, at the medial level, and also this top cherry on the top that is not completely 100% related, but it can help in 80% of the case, especially when you have a relative apical sparing with a ratio more than 1 between the apex and the base. And of course, all the alteration in hemodynamic parameters when patient is dyspnea with a raised high feeling pressure, right heart feeling pressure raised, etc., etc. Now, this is what I told you about the AI. It's very important. This is the most recent paper about AI showing you that if you give the machine or the AI with one 4-chamber single view, you will have an algorithm to detect this cardiac amyloidosis, and it was highly accurate in an international multi-ethnic validation data set, more than 2,800 patients with an accuracy more than 93%. And believe or not, they compare it to the typical scoring we are using, and it was better than the scoring we used to diagnose this disease, comparing to the TCS score and the interventricular wall score. Now, just remember that the PYP is really a key and cornerstone diagnosis for once you have the EKG, when you have the echo, you have the biomarker, and you have your suspicion, you have to go to the PYP. And if you have a severe uptake more than grade 2 or 3 without having any monoclonal gammopathy, you can diagnose amyloidosis with the 100% positive predictive value. So this is really has to be, in addition, not only the uptake by planner, but also by SPECT view to avoid this problem of blood pooling, which we'll talk later about it if you want. Now, see, again, the artificial intelligence is everywhere now, even with the PYP, with the MRI. If you combine all the information together, you put them, and you implant a machine, they will give you a very good, with the accuracy of more than 93% for this. So really, we need to go further. Now, the algorithm as a clinician can go from the cardiology if they present to us, or to the neurologist. So in all cases, you have some algorithm already published showing you that you have a neurological evaluation, unexpected neuropathy, which start with the more sensory symptoms, later on motor lotus, autonomic dysfunction, all of them, not explained by anything else. You will tell me, okay, doctora, but most of our patients have diabetes. Okay, but diabetes does not explain everything. Does not explain the dysfunction, does not explain the orthostatic hypotension, etc. So you have this also the other point that both for the cardiomyopathy and the neuropathy, the rapid progression of the disease. Within 6 months, they get worse and worse. So this is a red flag, and I heard neurologists talking about this rapid progression. On the other hand, you have this cardiomyopathy, which I show you, the red flags of echo, EKG, biomarkers, clinical manifestation, dyspnea, unexplained dyspnea with somebody who has otherwise healthy until now. You do, the monoclonal gammopathy is normal, and you have the BNP is unexpectedly very high, usually for the light chain more than 40,000, 60,000, and for the ATTR around 5 to 6,000. So in that case, you do the cardiac scintigraphy, the bone scintigraphy of the heart. If it's 2, 3 uptake, it's positive. You eliminate the light chain, then you go to the genetic testing to make sure it is ATTR mutant or wild type. On the other hand, you have to go to consultation for the hematology. Okay? Now, just to show you here quickly how everything together. There's many publications showing you the multimodality approach workup for the amyloidosis. In some cases, we need the MRI, but not all cases, because I had always this question about it. Okay? So again, you can see here this central illustration in this recent paper showing you that everything should go together, the scintigraphy, the echo, and the MRI sometimes, and putting all these red flags together. Don't forget the role of sometimes the extracellular volume. This is the guidelines for the chronic heart failure, the latest one, 21, showing you the central law of the bone scintigraphy, monoclonal gammopathy, workout, genetic testing, and the tissue biopsy in some cases, and in all cases for the light chain. Okay, this is just to show you a clinical case of 82 years which confirmed hereditary ATTR. All the signs we'll talk about are here. The thickness of the heart, so this is usually it's an easy case, okay? Usually in real life we don't have these cases, but this is a real case but came at late stage. You have everything high pulmonary hypertension, severe pulmonary hypertension, severely dilated LA, IVC not dilated, not collapsible, dilated, not collapsible, high apical sparing, etc. So you have everything else. When you put things together, you have to go to the PYP. Okay? This is another case, less obvious. Of course, it's less obvious because the thickness is less. The patient age is 67, and also the patient was really sick, and it was missed actually. It was missed, and he came to Riyadh at late stage, unfortunately, and the stroke volume was very low. The patient came with a pro-BNP 70,000. And of course, when it comes to that one, the patient really coming bad. This was light chain, but it was missed because the light chain patient don't go till 80 millimeter or 90 millimeter. They will die usually before. Okay, so the cardiac amyloidosis, the good news why I'm here is because it's a treatable disease, and we have modifying treatment. The aim of this modifying treatment, I will not talk about the supportive treatment that maybe you heard about already, that stop the infiltration process, stabilize the organ damage, improve quality of life, and obviously, ultimately decrease mortality and morbidity. Now, we have different options for ATTR, the mutant and the wild type. Today, I will not talk about the hematology treatment because it's more the people from oncology that deal with this. That we can either stop the production, either stabilize the protein. Remember, it was tetramer and becomes monomer or dimer, either disruption of the fibrils amyloid at late stage, but we don't have yet this step. So we can either stop the production and stabilize the protein, or both. But if you are rich, we can do both actually. And where it works inside the RNA silencer therapy mainly with 4 medication usually, inotersen, patisiran, eplontersen, and vutrisiran so far that are on the market, or at least. And for the tetramer stabilizer, you have the tafamidis and the acoramidis, which are available right now. This is again another way, more easy way to show how it works. Stop the production by the liver, you block the synthesis of the TTR by TTR silencer, gene editing, which we don't have yet, or you stabilize the tetramer, prevent them to go into monomer by tafamidis or acoramidis, or you you remove or deplete the TTR amyloid deposits from the organ themselves. Okay, next. Okay, so this is again to show you that the medications that are available so far, but I will focus more because it's today it's more focused on the RNA silencer, just to show you they have cardiomyopathy trials with acoramidis and tafamidis, and both of them are approved, but only so far for the guidelines we have the tafamidis. The main type of approval RNA silencer, you have the expression silencer, which are inotersen which is an antisense oligonucleotide, the patisiran, which is small interfering amaserase nucleotide, which is a class of small non-coding double-stranded RNA molecules that are difficult because we don't remember all the things when we are medical students. And we have the second generation small interfering RNA agent, which is the butisiran, and the new generation silencer using the LICA technology, which is represented today by the eplontersen, which is a ligand conjugated antisense, highly selective, designed to reduce the production of the transthyretin. The importance of this new generation, the most recent one, the new generation silencer for the treatment, is that it is enhanced targeting delivery to the hepatocyte, where the majority of TTR is produced. It reduces systemic exposure and obviously decreases the side effects, and it binds to the template of the TTR, the mRNA, and binds to the wild type and also to the variant, the hereditary one, and the result for degradation of TTR mRNA and lowers obviously the TTR protein production. So it's a very small phenomenon, but it's really very selective on the hepatocyte to certain RNA, and it decreases the toxicity of obviously of this medication. Now we have some study again about patisiran and the other cardio-neuropathy trial and cardiomyopathy trial, but we don't have available in Saudi Arabia. You have also the inotersen, but no improved survival with inotersen. And we have the LUSB that was last year about the LUSB was showing survival benefit in this, but we don't have it again available in Saudi Arabia. Now we have this phase 3 clinical program for the eplontersen with the neurotransform that is already published, but we are waiting for the cardiotransform result, which will be published next ESC, inshallah, in Munich, with the highest number of patients so far, 1,538 patients, and they include all wild type and hereditary one with mixed phenotype or other. So now you see the result of the eplontersen with the neuropathy trial, better quality of life, less neuropathy impairment, lower serum TTR concentration. For the other one, we don't have the result yet, but basically they divided patient in randomized control multi-international study, and they include patients with heart failure, 2 to ATTR, or wild type with at least one hospitalization, higher probability, all the same indication or the inclusion criteria for other study, but they will exclude patients with GFR less than 30 and some other problems, age toward 18 to 90 years, and they have to confirm, of course, the diagnosis of ATTR. Okay?
Please, Dr. Dania, you have 2 minutes to finish your...
So basically, just to show you that we have in this randomized 1-to-1 placebo eplontersen, and we're waiting the result. The endpoint will be the overall mortality, cardiovascular mortality, and the importance of this one is that it's self-administered. Patients don't have to come to the hospital. It's only 1 month dosing, and it can go at home. We don't need any other help for this one. And it's approved everywhere, including Kingdom of Saudi Arabia. Just to show you here that the biggest challenge now for me is how to work as a multidisciplinary in each hospital. I'm facing problem with working with my neurologist, with my all other colleagues in the So to conclude, we have a dramatic change spectrum of the cardiac amyloidosis. It was very rare, now it's much more common. It was poor awareness, now it's improved. The genetics was unknown, now it's well understood. The modality was biopsy, now it's multimodality imaging, non-invasive. The biomarker, we did not know how to use them, now we use them as a prognostic marker. Drug therapy only supportive, now we have disease-modifying disease. Management, it was only one physician, now it's a multidisciplinary team based, and outcome were very poor, and now they are improved. Thank you so much for it. Sorry for the delay.
Thank you, Dr. Dania, for this comprehensive and illustrative talk about cardiac amyloidosis. Question will be at the end of the session because for time. The next speaker was Dr. Ahmed Goha. He is the head of cardiac imaging department, expert in cardiac imaging. We'll discuss the cardiac manifestation and the complication of antiphospholipid syndrome. Dr. Maged Al-Anzi, head of internal medicine program in Ha'il and head of rheumatology department in King Khalid Hospital, will share Dr. Ahmed for discussion the manifestation and the cardiac manifestation of antiphospholipid syndrome. Fadal, Dr. Ahmed.
So today I'm going to present one case with Lipman-Sachs endocarditis as a complication of antiphospholipid syndrome, and Dr. Maged will give us a thorough discussion about antiphospholipid. This nice lady, she's 25 years old with no previous medical history. She was she sought medical advice because of transient loss of vision, lost for 1 hour. She had some exertional dyspnea. She had a brain MRI demonstrated bilateral scattered small subacute infarctions. She was referred for transthoracic echo. Her echo transthoracic echo showed a mass attached to the tip of her anterior mitral valve leaflet that is causing severe, significant mitral regurgitation. Four-chamber view also showing the mass attached to the left to her anterior mitral valve leaflet. So as we consider, we should think that not all valvular vegetation could be infective endocarditis. So this lady, her culture was negative. She didn't have any other signs or that put her into infective endocarditis. We should correlate our echo finding to the clinical presentation that we have. She had a lab investigation that showed that she had positive lupus anticoagulant, positive anticardiolipin, and positive anti-beta-2 glycoprotein. She was diagnosed as antiphospholipid syndrome, and she had vitamin K anticoagulant for like 4 months. And she was evaluated thereafter, and fortunately that the mass that was shown previously on the valve has disappeared, and the significant regurgitation that we showed before also disappeared. And now let Dr. Magid to give us a thorough summary about Lehmann Sachs endocarditis or antiphospholipid syndrome.
Assalamu alaikum. I want to take this opportunity to thank all organizing committee who invite me to participate in Third Heil Cardiology Consortium. You know, the antiphospholipid syndrome is very important topics for not only for physician or healthcare providers, also for all female and childbirth period. Can I start? كيف نرجع؟ So antiphospholipid syndrome is an ONU syndrome is acquired autoimmune disorder characterized by recurrent thrombosis and obstetric complications. The key antibody is lupus anticoagulant, beta-2 glycoproteins, and anticardiolipins. Epidemiology incidence from 1 to 2 cases per 100,000 individually. Prevalence 40 to 50 cases per year. Mortality significant reduction in the last decade from 50 to 80% to now less than 20%. So antiphospholipid syndrome, we said what we want to know, what is the difference between antiphospholipid syndrome, what we mentioned already, and antiphospholipid antibody. It is a heterogeneous groups of antibody directly against phospholipid and phospholipid binding protein that can be transient or persistent. We need at least 2 times presentation, 12 weeks apart to say this is a positive antiphospholipid antibodies. And we have a subtype can occur in primary condition or in association with systemic lupus or other rheumatological disease. So subtype will be thrombotic, obstetric, microvascular, and catastrophic. So primary was, as we said, it's detection of the antibodies, antiphospholipid antibody without any other systemic disease. Secondary can be associated with systemic lupus, Sjogren, rheumatoid, vasculitis, solid, and hematological malignancy, or with infection. So about half of the SLE patient can exhibit clinical manifestation of antiphospholipid syndrome despite presence of the antiphospholipid antibodies. So what is the pathophysiology of the antiphospholipid syndrome? Mainly there is an antibody binding to the blood proteins promoting clot formation. Other thing, 2-hit phenomena that need a second hit like infection, injury, pregnancies that cause vessel damage and accelerate clotting.
So the present with antiphospholipid will trigger immune system that's cause more inflammation that's further promote the clot. The second date lead to the excessive clotting and sticky vessel wall. So this mechanism also can be attributed to the all manifestation of antiphospholipid syndrome and also to the valvulars, valvulopathies, or atherosclerosis, myocardial ischemia, pulmonary embolism, pulmonary hypertension, and cardiomyopathies. So when we suspect antiphospholipid syndrome, when we have unexplained thrombosis or first pregnancy outcome, clinical sign like refidurticularis, heart valve diseases, neurological symptom, heart valve issues, association with autoimmune disease, laboratory unexplained thrombocytopenia, prolonged BPT, and false positive test for syphilis. So we recommend avoid testing in low suspicion individuals. So the thrombotics will be venous thrombosis, arterial thrombosis, or rarely catastrophic antiphospholipid syndrome. So for diagnosis, we had classification criteria. One is revised Soboro criteria, or it's called Sydney criteria, and other which contain 2 clinical and 3 laboratory. And we have a recent one, ACR EULAR criteria. This one contains 6 clinical and 2 laboratory domains. So depending on this, or we can compare between this criteria and the Sydney criteria, we need at least 1 point from clinical domain and 1 point from laboratory domain to meet the diagnosis. From the new criteria, we need 3 points from clinical domain and 3 points from the laboratory domains. So 6 points we needed to classify this patient can be classified as antiphospholipid syndrome. So other thing, importantly, we need to do the risk stratification for antiphospholipid syndrome. Low risk individually characterized by asymptomatic ABL carrier with no history of thrombosis or obstetric history, ABS. Risk margin for increased thrombosis risk by 1.2 annually, and high risk individually characterized by history of thrombosis, obstetrics, lupus anticoagulant positive or multiple ABL positive, or we can say triple or double positive, or resistant highly titers or SLE patient, and the risk for thrombosis exceed 30%. So the cardiology complication of the manifestation, or we can say complication of antiphospholipid syndrome, can be a minors, like cardiovascular manifestation like refidurticularis, can be vegetation in valve. So the main thing is valvular disease, valvular thickness, and non-bacterial vegetation, Liebman sac endocarditis, primary affecting mitral aortic valve, significant increased stroke risk. Other thing, high risk for coronary disease and left ventricular dysfunction. Can lead to the microvascular thrombosis and atherosclerosis, plaque ruptures. Other cardiac manifestation, angina, cardiomyopathy, and intracardiac thrombi. Risk of graft thrombosis after bypass surgery. So again, the same histopathology or same pathophysiology mechanism, but here we can say the valvular disease, immunoglobulin deposition causes inflammation and sterile vegetation like Liebman sac endocarditis and valve leaflet. Also, ABL create pro-inflammatory, pro-clotting state that accelerate atherosclerosis in the patient. Other thing, myocardial infarction can occur in 1.5 of the EBS patient, and EBS is found up to 15.5% of myocardial infarction with non-obstructive coronary artery. I think you say Minuka cases. Pulmonary hypertension preference is from 1.8 to 3.5, often due to pulmonary embolism or recurrent pulmonary embolism leading to the chronic thromboembolic pulmonary hypertension. So how can we diagnose this? The valvular disease diagnostic criteria include present of the ABL, echocardiogram, valve lesion like vegetation, moderate severe regurgitation, stenosis. Other thing, intracardiac thrombosis, we suspected if there is multiple cardiac chamber involvement, absent of the atypical anatomical context, confirmation by echocardiogram or cardiac MRI or autopsy. Important consideration exclude more common secondary causes, especially in young patients, screening
for cardiac valvopathy is generally reserved for asymptomatic patient. So usually when we have one antiphospholipid syndrome patient, we don't do the echoes for all patients unless there is symptomatic patient to have any murmur or clearly involvement of the heart. So management of strategy of the antiphospholipid syndromes, clearly it's very easy by this slide, but in the fact it's difficult. Low risk individually with low risk ABL profile, no treatment. High risk ABL profile with low risk individually, we can start it in low dose aspirin, like the when present of associated with the autoimmune disease. High risk individually, history of thrombosis, obstetrics, first thrombotic episode, recurrent thrombosis. First thrombotic episode, we start in vitamin K or warfarin with target for the INR from 2 to 3. Recurrent thrombosis, as you know, despite the vitamin K treatment, will be increase the target adding of low dose aspirin. So rule of direct oral anticoagulant, rule of the DUAC, current conflict efficacy compared to the vitamin K agonist, with one trial showing increased recurrent thrombosis with rifaxiban, dabigatran, and dabigatran maybe offer similar efficacy considerable for patient with VK contraindication. Limitation contraindicated in triple positive ABL with arterial event due to high recurrent risk, may be suitable for venous thrombosis with single or double ABL positive. So in general, valvular thickness, low dose aspirin is used, although the high quality evidence supporting its lacking. High risk valvular disease, patient with vegetation or prior systemic embolization, myocardial infarction, require anticoagulation, initiation with heparin, then transition to warfarin with target INR from 2 to 3, potentially with aspirin. Treatment goal, the antiplatelet therapy and warfarin prevent clinical emboli event and may facilitate regression of valvular disease, valvular lesions. Arterial thrombosis, mainly warfarin is target INR from 2 to 3. In the British guideline, I found some study for first episodes, they said regular dose of aspirin with dual antiplatelet clopidogrels can be effective as warfarin. But this is for only in the first episode, arterial thrombosis with antiphospholipid syndrome with significant limitation. We like our lovely old patient. So problem in old patient with EBS is big incidence and higher prevalence among those age from 55 to 75. It's male predominant, often present with single positive and primary EBS, increased risk for myocardial infarction, stroke, and pulmonary embolism, lead to shortening thrombotics, relapse-free survival, and reduce overall survival. Also, we consider in this populations increased ABL positivity in health older adult without any disease. Lupus anticoagulant is significant biological marker. Consider underlying malignancy in patient with thrombosis and high ABL titers. The treatment we will be cautioned with low dose aspirin for primary thromboprophylaxis due to high risk of bleeding. Vitamin K antagonists are mainstay therapy and target target INR from 2 to 3. Closing monitoring is crucial for all patients, especially those required higher INR target. So further perspective, novel treatment as patient, mainly in the patient with secondary antiphospholipid syndrome, we use rituximab, it's anti-CD20 antibody used as second-line treatment for refractory catastrophic EBS. Limitation include uncertain long-term efficacy, adverse effect, and high cost. Other medication we can use, it is not used now, but in futures, anti-CD38, daratumumab, is in autoimmune disease, including antiphospholipid syndrome, with highly synergism when combined with rituximab. Other medication, bintuzumab, this medication is approved now for lupus nephritis. It is type 2 anti-CD20s that's more effective at beta cell depletion than rituximab, especially in the tissues, more than in the blood vessels.
potential treatment for antiphospholipid cases resistant to the rituximab. So conclusion, management of the ABS cardiovascular complication is challenging, particularly in older adults, require delicate balances between thrombotics and bleeding risk. Other than current treatment, aspirin and warfarin have limitations. Safer, more target options are urgently needed. So from future direction, we have a lot of things under research, like emergent biomarker for antiphospholipid syndrome, show promise for early detection and risk stratification, especially for a typical presentation in older adults. Thank you.
Thank you, Dr. Magid, for this comprehensive lecture about antiphospholipid syndrome. Thank you, Dr. Goha. Dr. Abdullah will represent the second speaker.
It's my pleasure to present Dr. Tariq Al-Hassan, who's a consultant cardiologist and echocardiographer. He's going to talk to us about an important topic that we are seeing more and more, which is cardiotoxicity of novel cancer therapy. Dr. Tariq.
السلام عليكم. Good evening everybody. أود أن يعني أشكر الجميع على هذا المؤتمر الناجح وإعطانا الفرصة أن نكون هنا في أرض حائل مع أهل حائل أهل الكرم والعطاء. Thank you very much for inviting me to this presentation, and in particular I would like to thank Dr. Naif Al-Ghassab. Just a glimpse here. So Naif, he was trained in King Saud University. I was the program director at that time, supervising his training. He was an excellent fellow, just for the audience. So I would like really to thank him for this remarkable success and for this really wonderful meeting. So the topic is actually big, and I was asked usually to present it in 15 minutes, and that was really challenging for me. So I tried here just to give up like a summary or an outline about what do we mean by cardio-oncology. As you all know, cardio-oncology is a growing subspecialty. And since 10 years ago, now there is a fellowship dedicated for cardio-oncology, okay, because of the growing demand. As you know, the cancer and cardiovascular disease, they all interchange, and they are by far the two killing diseases, if we take them in the top-notch line for the risk of death globally. So a considerable knowledge is really behind the curtains whenever you try to explorate this huge topic. So I will start by some case scenarios that we face on everyday practice. So that's a 60-year-old female. She's receiving human epidermal growth receptor antagonist, which is the Herceptin, which is a very commonly used for breast cancer. It's considered the magical drug for the treatment of breast cancer and one of the cure. And her baseline echo was ejection fraction 60%. She was doing fine. Then 1 month later, on follow-up echocardiogram, that's her echo, and we can see there is a drop in ejection fraction, which is 40%, as well the global longitudinal strain. So the question is, what should we do? This is the case number one. Case number two, we have a 70-year-old gentleman who's known with metastatic lung cancer. He's on the oncology floor. They called you middle of the night. He had an inferior STEMI. So the question is that how would you treat him? So would you activate the cath lab? Would you give him fibrinolysis? Or you would treat him conservatively? So this is another challenge which when you face those patients. Another third case is a young gentleman who's diagnosed with Hodgkin's lymphoma. He's receiving an immune checkpoint inhibitor. This is an immune modulator therapy that modulate the T cells through 17 receptors and make them attacking only the cancer therapy instead of attacking the human cells. So he came presenting to the emergency room of shortness of breath. So once you have this clinical scenario, what do you suspect from these diagnoses? Would he have a tricuspid regurg? So whether he have a drug-induced valvular regurgitation, pulmonary hypertension, myocarditis, or symptomatic LV dysfunction. So we will go as we present through these cases during our presentation. So the information about biomarkers, cardiotoxicity, cardio-oncology is scattered all over, okay? But how we can bridge this knowledge, this is an excellent document published by the European Society of Cardiology. They published a really well-written guidelines. I encourage you all to go over it,
okay, they really addressed all the issues related to this subject in this document. So it's a very excellent document published in 2022. So as we know, the dynamics of cardiovascular toxicity when it comes to risk of cancer therapy and its relationship with cardiovascular disease, if we have here the blue line and the purple line are the long-term survival and the risk of different patients. So the one in the blue is a low-risk patient, and the one in the purple is the high-risk patient. So if you apply meticulous measures in the preoperative or the pre-chemotherapy protocol, and you do the proper surveillance in the early stage, and you apply the dedicated therapy, this was known throughout the time that you would really reduce the risk of cardiovascular events significantly. And this is actually throughout the continuum of therapy, even after completion of chemotherapy. So those patients, they need proper assessment pre, during, and also post completion of chemotherapy. So the cardiovascular toxicity axis assessment risk score, they need meticulous follow-up and screening. Usually our colleagues in oncology are seeing those patients. And for all those patients, they need meticulous workup, including all routine blood works, and more importantly, they need to have a baseline ECG, a baseline echo, and a baseline biomarkers, including troponin and BNP. These are very essential at the time and before you embark on the specific treatment. So the Heart Failure Association with the International Cardio-oncology Society, they came up nicely with a tool, or a risk tool. It's available there in the internet. Below is the link to the website, and it really tells you the risk of the patient, okay? So you apply which type of therapy that you are going to be given from all these protocols and all these regimens, and you choose whatever the patient has. So the demographic, including the age, other risk factors if they are there, if the patients have already an established cardiovascular disease, and at the end it will give you the risk for future toxicity. So it is categorized as low, mid, and high. So any person with a risk score more than 10%, we consider them as high risk. In general, all patients with established cardiovascular disease, okay, they do have a higher risk, which is greater than 10% when it comes to risk of future toxicity. So the risk score is very nice, and it has a very schematic diagram that tells you, so how can I deal with each patient in particular? So patients who are categorized as high risk, they need cardiology early referral before starting treatment. So we as cardiologists, we have to see those patients and we have to treat them accordingly. Those with low risk, okay, it's okay to start the chemotherapy, and later on, if future toxicity develops, they will need referral. What about those in the moderate risk range group? An early referral, it's a class 2B recommendation, okay? However, some oncologists, they opt to treat and start treating, but with close monitoring, and also this is really applicable in the guidelines as well. But remember that those patients who are high risk, they need early cardiology assessment, early cardiology treatment. You need to involve the patient, okay, in the decision. You need to really to address the risk versus benefit, and as well also, you need to do a multidisciplinary team or with a cardio, like we call it a cardio-oncology team, similar to the heart team. Okay, we discuss those cases and we try to come up with what's best for them. So in terms of primary and secondary prevention, we apply all our practices according to the ACC and ESC guidelines, okay? What about those who have established disease? We treat them accordingly as any other patient. Those who are at risk and who are labeled as moderate and high risk, it is okay to start them with ACE and ARBs, and also to include statins, okay? Because as we know, cancer and therapy can accelerate atherosclerosis, okay? This carries a class 2A recommendation, and this is new in these guidelines, okay? So those with at risk, who are at risk of developing LV dysfunction, it's a class 2A recommendation to initiate a small dose ACE inhibitor and also to put them on statins. So the surveillance is during the therapy is also very essential and also very important. So the mechanism is very complex, okay? There is direct toxicity of chemotherapy, as it can induce myofibrillary disorganization, apoptosis, and also can induce myocardial nephrosis. This can happen acute or chronic, or even it can happen late. Even those who stop the treatment and who are labeled cure, okay, sometimes they develop a latent cardiomyopathy. So they come after 1 year or 2 years with cardiomyopathy. So it's very important to keep track and following up those patients. Different regimens are associated with different diseases. So if you know, radiotherapy are associated primarily with pericardial diseases, okay, valvular heart diseases. We have also here anthracyclines are the commonest to cause heart failure and LV dysfunction, which is most commonly the doxorubicin, as well the human epidermal growth receptor inhibitors. The vascular endothelial growth factor inhibitors also, they can induce hypertension, and also they can induce thrombosis, whether arterial or venous, because of they cause vascular stiffness, and also they can cause vascular narrowing, so they can induce hypertension and thrombosis. The dasatinib, it's a very commonly used cancer therapy used for colon cancer, for lung cancer. It also can induce pulmonary hypertension as well. Vanditanib is a drug that can affect the potassium-calcium co-transport channels on the conductive tissue of the heart, so it can affect the QT and can induce malignant arrhythmias. So knowing all these is very essential and very important to know how to deal with those patients. So let's go back to our case scenarios. So in this middle-aged female diagnosed with breast cancer, okay, and she received the required therapy, her EF was very normal. 1 month later, she had a drop, okay? And noticeably, her EF dropped to 40%. So that's a significant drop from 60 to 40. And her global longitudinal strain also dropped by a factor of 18%. So how to deal with those patients? First, we have to categorize, okay? So the cardiotoxicity they came up with a definition. So any drop below 40%, irrespective of a normal baseline, this is considered severe. A drop between 40 and 50% is considered moderate. Those who are in the range of normal or low normal, but they only noticed a reduction in the global longitudinal strain, okay, we consider them, we have mild. And these are very common, okay, and those who are reading echoes in cancer patients who have follow-up protocols. We see a lot of times a drop, especially in the early stages, okay, of global longitudinal strain, but yet the ejection fraction is preserved. So very important to identify the drop, whether it's mild, moderate, or severe. The other thing is to assess whether the patient is symptomatic or no. Why is that important? Because this will really affect the management decision. So if a patient develops severe drop, so irrespective, all chemotherapy has to be discontinued, okay, and to be switched to another regimen. Those in the moderate range, okay, continuation with extreme follow-up, with good follow-up in asymptomatic patient can be applied. But those who have symptomatic moderate dysfunction also class 1 to discontinue the treatment and to have a multidisciplinary team decision. And those who develop the LV dysfunction, we treat them according to the standard guidelines of heart failure presented in the earlier session with all the pillars for the treatment of heart failure. So anthracycline-induced chemotherapy, this is a very nasty, okay, and it is associated more than 70% of the time with an irreversible damage. Therefore, whenever a damage is observed, which is more than moderate, we recommend discontinuation of therapy and change in the plan of regimen. So in our patient, she had a 40% drop with a global longitudinal strain. She was symptomatic, so that's a symptomatic moderate dysfunction, if you want to call it like this. So symptomatic moderate dysfunction will result, as per the guidelines, in discontinuation of treatment and changing the treatment modality. So case number 2, this is a 70-year-old gentleman in the floor. They called you middle of the night. The patient had an inferior STEMI. So how would you deal with that? So the recommendation is we need to look into two very important facts. And because whenever we are taking a patient to the cath lab for a primary PCI, we always give antiplatelet, we give heparin, so we have to assess what's the bleeding risk. And also, more importantly, the life expectancy. And this is really need discussion with patient, family, and the treating oncologist. So in general, those who have a life expectancy more than 6 months, they are functional, they are mobile, they have lower risk of bleeding, they deserve to be treated like any normal patient. But those who have a less than 6 month survival, it's a class 2A recommendation to treat them conservatively, okay? And again, you have to take it case by case, okay, and you have to look into all the particulars. Risk of bleeding is always there, as you know. Cancer in general can induce DIC state, can increase the bleeding risk, okay? And also, especially if you have GI cancer, this by itself can increase also cancer in the GI tract. So very important to look at the platelets and how it is the count. So in general, an absolute reduction in less than 10,000, usually this is against giving any antiplatelet therapy. Those who have in the range of 30 to 50,000, we usually avoid giving them ticagrelor and prasugrel. So if needed, we can give them aspirin and clopidogrel as the first choice. Another mode of therapy, which is the vascular endothelial growth factor inhibitor, okay, this is as we told you earlier, because it really affects the vasculature, okay, so it can induce hypertension, it can induce thrombosis. If those are detected, okay, so we treat them according to the guidelines, but the only twist here that the drug of choice is ACE and ARBs. Why they choose that? Because of the beneficial effect of ACE and ARBs in reducing prostaglandins, and they're also positive remodeling of the heart. So it can give protection on the long term, okay, if they will develop any subtle cardiomyopathy or any after-load increase related high output heart failure. So always the drug of choice is to start with ACE or ARBs in those who have hypertension induced by VGAI inhibitors. The QT prolongations, vanatidib, this is a very important drug that can affect and prolong the QT. So the treatment protocol for this, usually the patients are admitted, it is administered in the hospital.
دكتور طارق بعد إذنك 2 minutes.
I don't need more than 2 minutes. So the QT has to be monitored in the first 3 days, especially when you're giving the loading treatment. And if the QT at any stage of therapy exceed 500, this is an indication to stop and discontinue the treatment. If it's less than that, you can keep monitoring those patients. Pulmonary hypertension with dasatinib, it can be also induced, okay, in more than 30% of the cases. It can cause a 15 to 20% rise in pulmonary hypertension. So how we detect that is with regular follow-up. We keep track of our favorite TR velocity. If it's more than 3.4, it's a cutoff to consider a new incident of pulmonary hypertension, and that's a recommendation to discontinue the therapy. Last case, 20 years old gentleman who's receiving an immune modulator. He came with shortness of breath. So the commonest diagnosis associated with that is myocarditis, okay? And with all immune modulators inducing myocarditis, those patients are at very high risk of developing fulminant myocarditis. We need to adapt them. The drug of choice is to give them pulse steroid therapy, and if they are refractory or not improving, they can be given IV immunoglobulins. So these are the key takeaway messages to take up from this lecture. I try to summarize it here as much as I can. The cardiotoxicity and the proactive risk assessment is very essential, especially before treatment and also during the treatment journey and after completion, especially in the first 5 years. They will always need follow-up and at least a yearly echo, even after they are labeled cure. Risk association, and very important to know the risk tool, it's there, published by the HFA and the ICOS guidelines. Closely monitoring cardiac function throughout the therapy is very important. Immune-related myocarditis and the treatment of choice is steroids. You have to early identify those patients who are receiving immune modulators. Pulmonary hypertension, remember the cutoff is 3.4. Whenever you have a 3.4 velocity of TR rising in those patients, you have to alert the oncologist about this new finding. ACS management is very important, as because you know cancer itself accelerates atherosclerosis. So those patients, we really need to address their risk factors very aggressively. We need their LDL treatment goal to be consistently below 55, and to give them all the available kind of treatment. Thank you very much.
Thank you very much, Dr. Tariq, for this beautiful, comprehensive review about very difficult topic. It's my pleasure now to introduce my colleague and my friend, Dr. Fadl Mola from King Faisal Hospital. He's a consultant in clinical cardiology and professor of medicine in Faisal University, and he will talk today about his experience in HOCM patient. Please, the floor is yours.
Thank you, and first would like to thank the organizing committee for the kind invitation, and I'm very happy. This is my first time in Hail, 5 years in the kingdom. Today we'll just go. I will promise will be inshallah 15 minutes. I know it's a very long day. Novel therapies in hypertrophic cardiomyopathies. This is my declaration of interest. So agenda will be all in glance, short because it's 15 minutes, like we talk about evaluation, diagnostic of hypertrophic cardiomyopathies, prevalence and pathophysiology, clinical-based evidence for the first-in-class myosin inhibitor, which is a new medication that targeting specifically the disease, and the guidelines from the European and show summary. So to start with, this a case also I think will make in perspective. This is a 60-year male diagnosed with HCM 2011 after presented with exertional and anginal symptom, which is typical in this patient. That time, left heart cath showed mild coronary disease. This patient started on medication, beta blocker and other, however, not diagnosed with LVOT obstruction until 2014. At that time, his resting gradient across the LVOT was more than 50 millimeter mercury. On the long term, he developed permanent atrial fibrillation and anticoagulated, which is very common in this population, and they are very high risk of stroke, this patient. Just to remind our colleagues, don't use short bus score in this patient. If developed AFib, anticoagulate immediately. This patient, through the years, he tried a lot of combination beta blockers, non-dihydropyridine, CCB, like verapamil and diacalcim. Also, in our institute, we start him with disopramide. However, it failed also. Also, our senior colleague, interventional cardiology, tried to do alcohol septal ablation. However, it failed due to unsuitable septal branches. So the patient was being planned for surgical septal reduction treatment, which our center have very good experience with Professor Al-Halis. However, the patient was very educated, working, I think, in very administrative in Aramco. He read already about myosin inhibitor at that time. So this just now from ejection, he's more than 70, and you can see the patient very hypertrophied with clear SAM phenomena without doing M-mode, giving the breath. And we did it in our institution, that resting 55 with Valsalva maneuver, he reaching 100. So also just quick, this cardiac MRI, we do it routinely because Dr. Adania, because we should rule first, any patient with LVH, we should rule amyloidosis, especially in his age 68, and other infiltrative cardiac disease. So just for quickly about clinical diagnostic workup of all cardiomyopathies, I think for our colleagues, there is a very good step-by-step chart from the European Guideline Society from 2023, starting from the clinical scenario morphology by echo and cardiac MRI, then the phenotype, and then about that, the most important stratification of arrhythmia and sudden cardiac death, regardless which type of phenotype of cardiomyopathy. What about prevalence about HCM in general? It's this data from European population. I think we are working now, even here, there is a registry will be soon in the Gulf country, organized by King Saud University with all colleagues, multiple centers. So inshallah, we will have a data regarding HCM in the region, 0.2%. So just in quick also in glance, pathophysiology of HCM is complex. However, in general, this always starts with diastolic dysfunction, the main symptom. And secondly, also myocardial ischemia. Most of the patients will present with anginal symptom. When they do ischemia workup, they are normal, non-obstructive. They can also present like acute coronary syndrome with troponin leak and ischemia, even dynamic ECGs. When they do cath, it's minuca, there's non-obstructive. And also we should remember dynamic LVOT usually come with hypovolemia, tachycardia. And many patients miss diagnosis of obstruction when they take at rest without do Valsalva maneuver. Unfortunately, in late stage, patient can come with arrhythmia or reduced ejection fraction, which there is no other therapy than to be sent to center with advanced heart failure for transplant. So also the protocol for assessment of HOCM, now we go to HOCM specifically. With echo Doppler, we can, at rest and Valsalva guidelines, if 50 or equal or more millimeter mercury, then the patient have already obstruction, then you go to the management, medically will come later on. If the patient have no high and there is still symptom, then it's mandatory to do exercise echocardiography. Why? Because Valsalva, it depends on the who do it and the patient capability to do Valsalva. Very important, this also patient need multidisciplinary approach and specialized HCM clinic. It need a lot of from imaging and clinical cardiology, advanced heart failure cardiology, genetic, I forget about that, is a big part, but I skip it in this with the genomic medicine colleagues. So we go to the management. Traditionally, this HCM was managed first medication, still in the guidelines, actually beta blocker. Though the beta blocker have now almost 60 years, this small study, randomized placebo, those with symptoms, they start beta and they become good. No replication of that beta blocker study. Again, the base of it is negative inotropy, negative chronotropy to reduce heart rate, to reduce hypercontractility with this agent that will improve afterload, and the patient may be symptomatic. However, remember, some patients become bradycardia, even their symptom will be worse with this medication. Second, we have now the new medication came, a myosin inhibitor, which is specific targeted the activation of myosin. Other medication tried in this population without very good success. However, they advise most of them to start on RAS inhibitor, as been mentioned by before, because they have remodeling and they may protect them not to develop end stage with reduced ejection and also antifibrotic effect. So how myosin ATPase inhibitor work? This is small. In normal, this is the interaction between myosin and actin. It balanced that the patient have contraction but also have good relaxation. And those with HCM, they have genetically hyper-representation of myosin, and that would lead to hypercontractility and impaired relaxation and altered myocardial energetics. So mavacamten is the first one came myosin inhibitor. It blocked the myosin inhibitor, and that will reduce exposes myosin with actin, and that will decrease all the relaxation will be improved and reduce hypercontractility. The study that came in 2020, the first one randomized clinical trial, Explorer HCM, documented the benefit of this medication. And I think all we remember this study, randomized to mavacamten versus placebo with different doses, followed for 30 weeks for the primary and then 38. The primary endpoint improved in the peak oxygen consumption, and the study came positive for the mavacamten in both for the composite 1 and composite 2. Composite 1, they have less peak consumption improvement, however, also with improvement of NIA class. So what about the gradient? This is the most important objective that we see. The patient have in mavacamten average drop from 86 to 38 millimeters compared to placebo without efficient drop in LVOT obstruction. So also they did another study which I think more smart, Volar HCM. This patient qualified for septal reduction. They tried all medication, they persist, have high gradient, they have high symptom. They randomized to mavacamten versus placebo, and they check who is still qualified to go for septal reduction. So, and you can see here by the primary endpoint in mavacamten, from 100%, 82% is taken off from the list of septal reduction, while in the placebo, still persists 77 still on the list for septal reduction. So it's also effective. So what happened now in Madrid, the new publication, we know there came another medication, aficamten. It was documented and approved in 2024. They have a Sequoia study and document the same data of mavacamten. However, here they did smart things for the first time head-to-head with beta blocker, because we thought beta blocker is in the guidelines. I will show you class 1, they put it number 1. And did this study, and they have the result, and you can see it's the same peak oxygen consumption. Even in beta blocker, we know that even there is a reduction actually, not improvement. They may be controlled, but the patient will be limited physically, so even the consumption go down. In adverse, in the other side, in aficamten, they have better oxygen consumption. So this is also important for you, because many they thought mavacamten could be treating for non-obstructive. However, the study that published now and presented in the Madrid in the last Congress, Odessa, showing that for non-obstructive, this myosin inhibitor have no difference between the post-studies. There is many discussion. I think they will come sub-analysis. I think some of the patients could have effect, because the average follow-up or long-standing HCM by itself, if long, you will not benefit in non-obstructive. In the study, it was more elderly population, average 10 years. I think they will do now in younger. They anticipate in younger people may benefit from this study. Publication will come. So now I just remember here, I said the guidelines will tell us symptom, documented, start beta blocker class 1. Actually, there is one randomized study. So I don't know why they give it like that. Anyhow, and then they go to rapamyl, daltesim, and then you go for myosin inhibitor, mavacamten, or disopramide. However, I think now myosin should be, there are 3 randomized clinical trials, 2 from mavacamten and 1 from aficamten. I think the new guidelines will make it up in the scale. So what here in the guidelines also, it's allowed to use it as monotherapy. This already from 2023, because we know that for patient, they have bradycardia, you cannot start in disopramide or beta blocker or CCB for that. So American guidelines may be better in 2024. They make myosin inhibitor the same with disopramide. However, they still kept beta blocker as number 1 selection with verapamil and daltesim. So we go back to our case when we are finished. So this patient started on mavacamten. We have now good experience, 5 milligram. Usually we do cytochrome test for them, because some of them, they are poor. Some of them, they are rapid metabolizers. This may affect metabolism. However, our experience, it doesn't match this cytochrome. 5 milligrams, this patient just after 4 weeks, as we remember this, I show you in the start. Now we can see what happened to his, even you can see, you see the cavity. Before you don't see left ventricle cavity. So in this patient, they reduce contractility, yes, but the patient still 50-55, and definitely there is no obstruction as seen by the Valsalva or by at rest. And the patient improves symptomatically, definitely. This, I take this also echo from Olivetto, who did a study of Explorer, and he followed their population for 3 years. And the good thing, there is no harm. There is no drop of 3 years of using of myosin inhibitor. So to conclude, HOCM is a dynamic subtype of HCM disease that causing poor quality of life of affected individuals. The key aspect and clinical workflow now, we have a very good guidelines from the European Society how to sort this patient and to navigate.
it's recommended that suspected individual with HCM in general and HCOM to be referred or treated in specialized clinic. Mavacamten is a first-in-class target cardiac specific myosin inhibitor that showed significant improvement in physical activity, quality of life, and normalization of LVUT in the most of the patient. Aficamten also have the same. Use of myosin inhibitor also led to reduction of many referral to septal ablation, either alcohol or surgical, especially in our center in King Faisal. We see a lot of reduction, no more to do this surgery. And myosin look like very safe and well tolerated. And most important, non-obstructive HCM do not benefit from myosin inhibitor as per last publication. Thank you.
Thank you, Dr. Fadel, for this illustrative and comprehensive presentation about novel medication in HOCM. I have a question for new medication, mavacamten. There is any study compare this medication to septal myectomy as long-term survival?
Yeah, I think for sure no, because as you mentioned, the did study surgery is surgery. My patient, this I show it to you, we ask him, I think, many times about you have no way surgery. So surgery is surgery, and they tried alcohol ablation. This was more simple and more less invasive. He refused. No, and I will not anticipate will be studies that go to surgery or take pills. If you are a patient, what are you going to choose?
I have a question for Dr. Dani. For patient diagnosed to have symptomatic aortic valve stenosis and diagnosed also to have amyloidosis, any pre-procedure before TAVI, exercise or work, like any concern pre-procedure we need to consider before TAVI?
Thank you, doctor. So the question is, if you diagnose someone with aortic stenosis and amyloidosis, and you want to do TAVI, do we need any other pre? Actually, initially there was study showing maybe that the patient with AS and amyloidosis they are higher risk for TAVI, but then later on, all the study coming from London, from Vienna showed there is benefit, but there is no additional risk. And of course, if the patient has good protoplasm, I say for the TAVI. If he doesn't present something else that prevents him to benefit from the TAVI, but he will benefit exactly the same. So you don't need to do any other procedure. Now the 6-minute walk test, if you want, you can do it, but it will not change the management if the patient has truly indication for the TAVI.
We are seeing our colleague do a lot of bone scintigraphy to differentiate ATTR from the other type, in elderly going for TAVI. What's your feedback about the bone scintigraphy? Is it accurate? Is it needed?
Yeah, so to be able to diagnose the cardiac amyloidosis, as I showed you on the algorithm, we must do the PYP, the bone scintigraphy of the heart. They call it bone scintigraphy, but it's actually scintigraphy of the heart, but they use the tracer of the bone to make sure. But this is the diagnostic test. So without the bone scintigraphy, you cannot at least be sure that you have diagnosis. You will not do a tissue biopsy during the TAVI. You could, but usually we don't do that. Most of the time, you do the echo, you do the EKG, you do the bone scintigraphy if you have red flags. Once you have the PYP, and it's very positive, grade 2 or 3, and on the same time, you do the lab test to rule out the other disease, which is hematological disease, the light chain, yes, you're done. You know that this patient has both disease, and if your heart team say, yes, he needs TAVI, you go ahead and you do it.
Okay, I just have one question for Dr. Abdullah there. You just show us a case, I think, at the end was from Japan regarding balloon angioplasty of the pulmonary arteries. Are you aware about what balloons they used? Was it like
regular non-compliant?
Just regular non-compliant?
Or compliant, semi-compliant?
Thanks a lot for this session. I learned a lot actually outside intervention cardiology. But to ask more about the mefemectan, I have two questions. One, is it work for all pathologies of hypertrophic cardiomyopathy, obstructive one? Because we know that some of the pathology is related to the long leaflet, and some is because of position of the papillary muscles that give you that kind of obstruction. It's not all related to the septal hypertrophy. You might find some septal hypertrophy 1.8 and 1.4. Do you still gonna use it, especially if you do find another pathology like long leaflet or other pathology that can explain why the patient have hypertrophic cardiomyopathy? That's the question for you. And the other question for Dr. Tariq is a harder kind of thing, but do you find that actually finding algorithm for these patients of cardio-oncology that goes to the clinic is much kind of easier than, you know, with the going for dedication? For example, like your example that you showed earlier, if a patient on a certain chemotherapy, he will be in a regular kind of follow-up of echo or a kind of BMB, and it is kind of can be followed by the oncologist or even a cardiologist, but it's a different kind of follow-up of called cardio-oncology, because cardio-oncology will be found in big centers. But let's say we are in Hyel here, and there is a deficient of even cardiologists. So how is the advice to find this algorithm and where to find it?
Thank you.
Okay, I think very smart question, a very good question. Because we think first we should have diagnosis HCM we do all workup, including the thickness is not, you can have 1.4, 1.3, even you can have some bulk in the septum that causing for that patient. However, if like elongation of the mitral leaflet or other, this will not benefit, because we should think this will reduce contractility. And you see the last echo I showed you for 3 years, very thick, it's almost was 1.7 to start, and then the patient end diastolic, the thickness almost 1.4. So the hypercontractility decrease, ejection, this why open. So if not dynamic due to this myosin actin hyperactivity, they will not benefit. So not be used out of this equation.
Bottom line, if you have any amyloid or Hawkins, send him to King Faisal Hospital.
Very grateful for all the presentations. Allah يعطيكم العافية. Dr. Tariq Hussein, most welcome. Bring back memory صراحة. We're happy to have you and all the speakers, guest speakers. So one question for Dr. Dania Maudi. In regard to amyloid, Dr. Dania, in regard to amyloid, so backing up the question of Dr. Wael Gashkari, that we are seeing more trend of aortic stenosis with amyloid disease. And frankly saying, there are few papers that mention probably these patients with amyloid disease sometimes present with severe aortic stenosis, or the opposite, vice versa. But I have seen a lot of bicuspid aortic valve, early stenosis, where we suspect that amyloid is part of the equation. In those circumstances, should we tackle the amyloid, or is it a high index suspicion when we have certain bicuspid aortic valve or early diagnosis of aortic stenosis in those circumstances that we have to refer to do the workup entirely for amyloid disease?
Okay, I have one. So your question is, you're seeing more and more aortic stenosis, amyloidosis in patients with aortic stenosis, right? Even in the bicuspid aortic valve patient.
Yes, but sometimes we are seeing the pattern of LVH, in fact, of amyloid in those circumstances in early, less than age of 65, where they have a bicuspid aortic valve and early progression of stenosis there. So when do we need really to refer those patients to do amyloid workup entirely?
Well, I mean, this is a very good question. In the initial cohort in the United States and Europe, the prevalence was very high.
in the TAVI population, patient mainly because they are old. So we had like maybe 15% of each TAVI cohort having amyloidosis. And the recent cohort from Cleveland, they found only 5% of the aortic stenosis population having aortic amyloidosis. Why? And the explanation is that the patient who come to TAVI now, they are younger. So the more they are younger, the less obviously you can find. Now, concerning your question, all the guidelines said we should start working up a patient with amyloidosis for age more than 60 years, and for patient with some red flags by echo or by MRI or by clinical or by EKG. Now, if you feel yourself that your patient, irrespective of the bicuspid, because if the bicuspid live enough longer to develop amyloidosis, then this is part of the aging, because we don't know the relation between aortic stenosis and cardiac amyloidosis. The most suitable explanation, the aging process, the oxidative stress, not really the deposit of the amyloidosis inside the aortic valve, if I make myself understood. So it's only an aging process, oxidative stress, inflammatory, chronic inflammation. So if your patient has lived enough with bicuspid or whatever, yes, if you have your red flags and you feel like this patient has cardiac amyloidosis, go further and rule out by PYP and eliminate the light chain. All the series of the light chain did not find a lot of aortic stenosis. So most of the time you will not find light chain. Is it answered your question? For the surgery, all the series for surgery, less than 5%. Why? Because this patient, because they are in low, high risk and old, they don't refer, her team don't refer them to surgery, but more over to TAVI.
Thank you very much. So for your question, the first part, which is about the algorithms are already there in the European Society of Cardiology guidelines. If you go in the website, okay, there is already a published, you will find a comprehensive document. There is also pocket guidelines and a slide set. In all of these, you will find very nicely the algorithms you asked me about. The other center you said about big institutes. So whenever you have an oncology center, cardiac center, a tertiary cardiac center in-house, you will have MDR, usually multidisciplinary team decisions about patients about chemotherapy. So the question is about, I am here in Hyde, what should I do, okay? So you will definitely have lots of those patients coming to your clinic, okay? Lots of those patients are having routine, regular echoes. Those who are reading echoes, I am sure that every day in your inbox, you will find patient, breast cancer on chemotherapy, follow-up echo. And you are reporting echoes every time. So what should you do? Very crucial and very important to report the global longitudinal strain, okay? And you have to do it in every echo lab, okay? And it has to be documented in the echo report. The ejection fraction, you can use 3D volumetric, okay? You can use the standard Simpson method, okay? This has to be documented very clearly in every summary of report for those patients. So what do I need, when do I need to worry? Of course, if a patient develops symptoms or a new onset heart failure or a significant drop, it will be easily catched, easily managed. You will manage him according to the guidelines, and you will alert his oncologist. But very importantly, you need to watch for the subtle cardiomyopathy, which starts with a drop in the longitudinal strain by more than 15%. So if somebody is consistently in all of his echoes, his global strain is minus 20%, minus 20%, minus 20%, and then he comes the next time with a minus 11%. So that's almost a 50% drop. Even if the ejection fraction is preserved, so this is an alarm. This is the patient where you will need to alert his oncologist about a new finding, a new subtle finding. These are very important for you to follow up with your daily practices.
Thank you all. I think we reached the end of this session. It was very nice discussion. Thank you all for your attendance to the end of the program. We want to just give a simple gift to our speakers. So we'll start with Dr. Dania Mu'ti, the consultant from King Faisal. You join us on the stage to دكتور فضل المولى. دكتور طارق الحسين. دكتور عبد الله الخضير. دكتور ماجد العنزي. So if you allow me to take a group photo please for all